Welcome to the deep dive. Today we're taking a profound plunge into a part of the human body that is absolutely essential, incredibly complex, and frankly often overlooked or even a bit taboo. We're doing a deep dive into the anus and the anal canal.
Right, and this region is, well, it's a marvel of intricate anatomy and finely tuned physiology. Understanding its structure and function is absolutely critical,
Definitely.
not just for medical professionals, but really for anyone seeking a truly informed understanding of their own body.
Exactly. Our guide for this deep dive is a comprehensive body of source material, heavily drawing from key surgical texts.
Yeah.
These sources offer an incredibly detailed look at the anatomy, the delicate physiological controls, how we examine this area, and a wide spectrum of conditions that can affect it.
Yeah, this isn't about skimming the surface. It's really about getting to the foundational details, exploring the layers, the muscle interactions, the nerve supply, and connecting all of that to why and how things can go wrong clinically. It's the kind of knowledge that separates surface level understanding from true insight.
Right. So our mission is to unpack this material and extract those crucial insights.
Yeah.
We want to give you that shortcut to being genuinely well-informed, like you've absorbed the key knowledge an expert relies on,
Yeah, the core stuff.
but without needing to attend years of medical training. We'll explore the structure, the sophisticated control systems, the methods of clinical assessment, and then tackle the range of conditions from the surprisingly common to the more complex and serious. Get ready to delve deep.
Okay, let's begin by defining the landscape, the physical boundaries of the anal canal itself. Where exactly does this critical segment of the body start and end?
Okay, think of it as a transition zone. It starts where the rectum, that's the final section of large intestine storing stool, passes down through the muscular floor of the pelvis, the pelvic diaphragm. There's a point where the widened rectal ampulla narrows significantly as it enters this muscular sling. That point marks the beginning of the anal canal.
Okay.
It then extends downwards to the anal verge, which is the external opening, where the lining changes to skin.
And that junction where the rectum narrows as it passes through the pelvic floor, that's marked by a key muscular landmark, isn't it?
Yes, it's called the anorectal ring. It's not a single muscle, but actually a ring-like structure formed by the fusion of two crucial muscles, the puborectalis muscle and the deep part of the external anal sphincter. When a clinician performs a digital rectal examination, they can feel this ring as a thickened, firm ridge, particularly noticeable posteriorly and laterally. It's a vital landmark, both anatomically and functionally.
In the length. It's quite short compared to the rest of the GI tract.
It is. In adults, it typically measures just 3 to 4 centimeters. The sources note it's slightly longer in adult males than in females.
And its position isn't isolated. It has important relationships with neighboring structures.
That's key. Posteriorly, it's separated from the coccyx or tailbone by the anacoccygeal ligament.
Okay.
Anteriorly, the perineal body acts as a separator. That's that fibromuscular tissue between the anus and the genitals.
Right, the central perineal tendon area.
In males, it's between the anal canal and the membranous urethra and the bulb of the penis. In females, it separates the anal canal from the lower vagina.
Okay.
And laterally on either side are the ischiorectal fossae, those large spaces filled with fat surrounding the anal canal below the pelvic diaphragm.
Understanding those relationships really helps understand how infections or diseases might spread, doesn't it?
Absolutely. It maps out the neighborhood, so to speak.
So this brings us to the control system, the muscles and sphincters that enable us to store and pass stool voluntarily. The puborectalis muscle plays a starring role here.
It absolutely does.
Yeah.
The puborectalis is a U-shaped muscle sling, part of the larger levator ani muscle group forming the pelvic floor. It loops around the back of the anorectal junction. Its primary function, and why it's so critical for continence, is maintaining the anorectal angle. That's the angle or bend between the rectum and the anal canal.
And how does maintaining that angle help with continence?
Well, when the puborectalis is contracted, it pulls the rectum forward, creating a sharp, almost 90-degree angle.
Like a kink.
Exactly like a kink in a hose. This acute angle significantly helps prevent stool from inadvertently entering the anal canal.
Yeah.
To have a bowel movement, this muscle must relax, straightening the angle and allowing stool passage.
So the position, length, and angle of the anal canal are fundamentally reliant on this muscle's integrity and strength,
Precisely.
and its nerve supply gives us a clue about its control.
Yes, it's supplied by the sacral somatic nerves.
Yeah.
This means it's under voluntary control, although it maintains a significant resting tone, even when we're not actively, squeezing.
Right. Next, let's talk about the external anal sphincter. This is probably the muscle we most consciously associate with holding on.
It is. The external anal sphincter forms the largest bulk of the entire sphincter complex. Traditionally, sources described it as having three distinct parts: deep, superficial, and subcutaneous.
But the material references Golayer's perspective on this.
Right. Goler reviewed it less as three separate muscles and more as a single continuous muscle structure. The appearance of subdivisions is largely due to extensions of the longitudinal muscle layer weaving through the external sphincter.
Okay.
So think of it less like stacked rings and more like a muscular sleeve that's partially compartmentalized by other connective tissue fibers.
Okay. And like the puberectalis, it has attachments.
Yes, some fibers attach posteriorly to the coccyx, and anteriorly they blend with the muscles of the perineum. Functionally, it's a somatic, voluntary muscle, meaning we have conscious control over it. It's supplied by the pudendal nerve.
Pudendal nerve, got it.
And when surgically viewed, it's described as being red in color, consistent with voluntary muscle tissue.
Now, for the internal sphincter, this one operates on a different system entirely, doesn't it?
That's correct. The internal anal sphincter is purely involuntary. It's essentially a thickening about 2 to 5 millimeters thick of the circular smooth muscle layer of the rectum.
Okay.
It starts where the rectum passes through the pelvic diaphragm and extends down to just above the anal orifice.
Can you feel this during a clinical exam?
You can. You can feel its lower edge as a slight indentation or groove known as the intrasphincteric groove.
Okay.
Just below this groove is the subcutaneous part of the external sphincter, separated from the internal sphincter by a layer of connective tissue called the anal intermuscular septum.
Okay. What does the internal sphincter look like and how is it innervated?
When exposed, it's described as pearly white, with its circular fibers clearly visible. It's primarily innervated by the autonomic nervous system, which controls involuntary functions like digestion.
Right, the automatic stuff.
But here's where it gets really interesting. The course highlights the presence of intrinsic, non-adrenergic, and non-cholinergic nerve fibers within the internal sphincter itself.
And these intrinsic fibers have a surprising effect.
Yes. They release the neurotransmitter nitric oxide. And when these fibers are stimulated, nitric oxide causes the internal sphincter to relax.
Relaxation. Why is that surprising for an involuntary sphincter that maintains resting tone? And why is it crucial?
It's surprising because you might expect an involuntary muscle to just maintain a constant squeeze, right?
Yeah.
But the ability to relax reflexively is key to discriminatory continence. When stool or gas arrives in the rectum and distends it, this rectoanal inhibitory reflex kicks in.
Okay.
This causes the internal sphincter to briefly relax, allowing the contents of the rectum to momentarily come into contact with the highly sensitive lining of the lower anal canal, the anoderm.
Connecting back to the anatomy of that sensitive anoderm we mentioned earlier, the part below the dentate line.
Precisely. That brief contact with the anoderm allows us to differentiate between whether the rectal contents are solid, liquid, or gas. Yeah. This information is relayed to the brain.
So you know what's there.
Exactly. It allows us to decide whether it's socially acceptable to evacuate or if we need to hold on. The internal sphincter then regains its tone quickly. This reflex and the differing recovery rates of tone are a vital mechanism for maintaining fine-tuned control. It's a truly sophisticated gatekeeping function.
So continence isn't just about conscious squeezing, it's also about this automatic discriminatory process enabled by the internal sphincter's reflexive relaxation. Fascinating.
Exactly. It's a coordinated dance between voluntary and involuntary systems. Now, there's another muscle layer we mentioned that runs between the sphincters, the longitudinal muscle. What's its role?
Right, the longitudinal muscle. It's a direct continuation of the outer smooth muscle layer of the rectum, and it also gets some additional fibers from the striated pelvic floor muscle superiorly. It runs downwards in that potential space between the internal and external sphincters.
The intersphincteric plane.
That's the one, the intersphincteric plane.
And it doesn't just stop there, it branches out.
Correct. As it reaches the lower anal canal, it splits into multiple terminal septa. These fibrous extensions surround the bundles of the subcutaneous external sphincter and insert into the skin of the lower anal canal and surrounding perianal area.
Okay.
The most medial of these septa, wrapping around the lower border of the internal sphincter, form that anal intramuscular septum we mentioned earlier.
So it's creating this internal scaffolding and defining planes within the sphincter complex.
Yes, and these extensions aren't confined to just that area. They also send fibers medially, crossing the internal sphincter to reach the submucosa, and laterally crossing the external sphincter and extending into the fatty ischiorectal space to attach to the fascia of the pelvic sidewalls.
Wow, it really gets around.
It does. This framework provides structural support for the anal canal. Crucially, these extensions also create potential pathways for the spread of infection from the intersphincteric space into other areas, which is vital for understanding abscesses and fistulas later on.
It sounds like this longitudinal layer, though less prominent than the sphincters, is fundamental to the structural organization and potential disease spread. What about its function in defecation?
It plays an active role. During defecation, its contraction helps to widen the lumen of the anal canal, flatten the anal cushions, which we'll discuss next, shorten the anal canal length, and even invert the anal margin slightly.
So it helps open things up.
Right, facilitates the passage of stool. After defecation, its relaxation allows the anal cushions to return to their normal position and distend, helping to create that necessary airtight seal.
It's a much more dynamic contributor than just being a layer between the sphincters.
Indeed, it's involved in shaping the canal for emptying and then restoring it for continence.
You mentioned the intersphincteric plane, the space between the external sphincter laterally and the longitudinal muscle medially. How significant is this potential space?
It's a critical anatomical and surgical space. For one thing, it contains the intersphincteric anal glands.
The origin of most abscesses.
That's the theory, yes. They are the likely origin point for the vast majority of anorectal abscesses and subsequent fistulas. And as we discussed, the extensions of the longitudinal muscle create potential routes for infection to spread from this plane. For surgeons, this plane is important because it can be carefully explored to access the sphincter muscles during certain procedures while preserving surrounding structures.
Okay, now let's look at the lining of the anal canal, the epithelium, and the structures just beneath it. How does the surface change as you move down from the rectum?
Okay, starting from the rectum, you have typical pink columnar epithelium. As it transitions into the upper anal canal, passing through the anorectal ring, it changes to a zone lined by cuboidal epithelium, sometimes called the transitional zone. This zone features 8 to 12 vertical folds known as anal columns. Between these columns are small pockets or indentations called anal sinuses, and at their lower ends are small folds called anal valves or the crypts of Morgagni.
Well, Morgagni's crypts, they pop up later, don't they? And the line formed by the columns and crypts has a specific name.
Yes, the dentate line or pectinate line. It has a sort of serrated appearance. From an embryological perspective, this line is traditionally considered the junction between the hindgut, derived from endoderm, and the proctodeum, derived from ectoderm, essentially outer skin.
And that origin explains a fundamental clinical difference: sensation.
Exactly, sensation. What type of lining is below the dentate line?
Below the dentate line, extending down to the anal verge, is the anoderm. This is lined by non-keratinized, stratified, squamous epithelium, similar to skin, but without the hair follicles or glands found in the perianal skin further out.
Okay.
What it does have in abundance are somatic sensory nerve endings, specifically described as Wedel's nerve endings.
And why is the presence of these somatic nerves so clinically significant?
Because somatic nerves transmit acute pain, temperature, and touch with high sensitivity. So any injury or condition affecting the anoderm below the dentate line, like an anal fissure, a thrombosed external hemorrhoid, or a surgical incision in this area, is typically exquisitely painful.
Whereas above the dentate line,
Tissues above the dentate line with visceral innervation are much less sensitive to sharp pain, but are sensitive to stretch and distension.
that explains why internal hemorrhoids, which are above the dentate line, can bleed painlessly. But a fissure, or an external thrombosed pile, is agonizingly painful. The dentate line is literally a pain line.
It is a crucial boundary to understand clinically. Beneath the epithelial layer is the submucosa. What's supporting everything there?
Right, the submucosa. It lies between the lining epithelium and the internal sphincter. It's a complex layer containing blood vessels, muscle fibers, and connective tissue. The sources describe how those medial extensions from the longitudinal muscle we discussed cross the internal sphincter and integrate into this layer, providing structural support and blending with the intrinsic smooth muscle of the submucosa, sometimes called the mucosal suspensory ligament.
And this submucosal layer plays a role in organizing the blood vessels too.
Yes, this meshwork of supporting tissue effectively separates the superior hemorrhoidal plexus, which drains into the portal venous system, from the inferior hemorrhoidal plexus, which drains into the systemic venous system.
Right.
The mucosa in this region is also more firmly attached or tethered to the underlying internal sphincter compared to the rectal mucosa above.
And the sources mention age-related changes here that contribute to a very common condition.
Yes. With normal aging, the smooth muscle component of this submucosal supporting meshwork is replaced by fibroelastic tissue, which can fragment over time. This loss of elasticity and structural support contributes significantly to the development and prolapse of hemorrhoids, those swollen vascular cushions we'll discuss later.
Okay, having mapped out the structure in layers, let's look at the vital plumbing, the blood and lymphatic supply. The sources bring up an interesting point about hemorrhoids and blood vessels here.
Yeah, there's been historical debate about the exact nature of hemorrhoids, whether they are simple varicosities or specialized vascular cushions. Thomson's work, referenced in the sources, showed that the blood supply to the submucosa of the anal canal isn't solely from the superior rectal artery.
Ah, okay.
The middle and inferior rectal arteries also contribute. And importantly, there's free communication between the venous tributaries draining into the superior, middle, and inferior rectal veins.
And this is where we get that truly insightful and perhaps surprising fact about hemorrhoidal bleeding.
This is it. This is a great one. The sources highlight the presence of direct arteriovenous communications within those submucosal vascular dilatations that make up the anal cushions.
Direct shunts between arteries and veins.
Yeah.
Bypassing the capillaries.
Precisely. What this means clinically is that the blood contained within these vascular cushions, even though they are considered venous plexuses, has a significantly higher oxygen tension. It's more like arterial blood than typical venous blood.
Uh-huh. That explains why hemorrhoidal bleeding is characteristically bright red. If they were just swollen veins, like varicosities, you'd expect darker, deoxygenated venous blood.
That is the classic aha moment. The bright red color of the bleeding is a direct consequence of these arteriovenous shunts. It's a key detail that informs our understanding of their physiology. It's not just venous bleeding.
How does the blood drain away from this region then?
The venous drainage generally follows the arterial supply and is divided regionally. Blood from the upper half of the anal canal drains upwards via the superior rectal veins, which are tributaries of the inferior mesenteric vein, connecting into the portomesenteric system leading to the liver.
Okay, portal system.
Blood from the middle part drains into the middle rectal veins, which go to the internal iliac veins in the pelvis. The lower half, including the subcutaneous perianal plexus, drains via the inferior rectal veins, which eventually join the internal iliac vein system as well. Systemic drainage.
And lymphatic drainage, important for tracking disease spread.
Similar to venous drainage, the lymphatic drainage is also regional. Lymph from the upper half of the anal canal drains upwards to the mesorectal lymph nodes, then along the inferior mesenteric chain to the para-aortic nodes in the abdomen.
Okay.
Lymph from the lower half drains laterally to the superficial inguinal lymph glands in the groin, and then potentially to the deep inguinal group.
So if a cancer develops in the lower anal canal, you'd look for potential spread to the groin nodes.
Exactly.
While a cancer higher up might involve abdominal nodes.
Precisely. That difference in lymphatic drainage is clinically vital for the staging and management of anal cancers. Where it drains tells you where to look.
That was a really thorough dive into the fundamental anatomy and physiology. The sources summarize these key points well, emphasizing the coordinated roles of the sphincters and puberectalis, the importance of the anorectal angle, the distinct sensation above and below the dentate line, and the blood lymphatic drainage patterns. It's clear how interconnected all these components are.
It truly is a complex, integrated system where each part contributes to the overall function of continence and defecation. It all has to work together.
Now that we understand how this area is built and how it's supposed to function, let's explore how clinicians examine it. The sources stress that a careful clinical examination is paramount, and can diagnose the vast majority of anal conditions.
It is the cornerstone, absolutely. But it requires the right setting and approach. You need a private environment, ensuring the patient feels relaxed and is informed about the process. A chaperone is standard practice,
Good point.
providing security for both the patient and the clinician. And good lighting is essential for thorough inspection. You need to see properly.
And the position matters.
Yeah.
The left lateral position seems to be the standard.
Yes, the left lateral or Sims position is most common. The patient lies on their left side with knees bent, particularly the top one, positioned near the edge of the couch. This provides good access for both inspection and digital examination. The sources also mention alternative positions like prone jackknife, knee elbow, sometimes used in children or for specific procedures, or supine with stirrups. The choice might depend on the patient's comfort, the specific condition suspected, or if other pelvic structures need assessment.
So you start with visual inspection. After asking the patient to part their buttocks, what are you looking for right away?
You're looking for any visible skin lesions in the perianal area, conditions like psoriasis, lichen planus, anal warts, candidiasis, lichen sclerosis, or even herpetic vesicles.
Right.
Note if they seem confined to the perianal skin or if they're part of a more widespread dermatological condition. You also observe for signs of anal leakage or if the anus appears open, sort of patulous, or tightly closed at rest.
It's also important to assess dynamically, right?
Yeah.
Not just at rest.
Yes, definitely. Ask the patient to bear down like they're having a bowel movement. This can reveal conditions like prolapsing internal hemorrhoids or even rectal prolapse that might not be apparent when they are relaxed.
The sources highlight pain on parting the buttocks as a key visual cue.
Absolutely. If the patient experiences significant pain just from separating the buttocks, especially if there's a visible skin tag, a sentinel tag, or a crack in the lining,
Fissures.
it's highly suggestive of an anal fissure. However, the sources correctly caution that such pain or an atypical appearance should also raise suspicion for other potentially more serious conditions, like anal squamous cell carcinoma, particularly if adequate examination is difficult due to pain.
So you might need to investigate further.
Exactly. In such cases, examination under anesthesia and biopsy might be necessary to rule out malignancy.
After the visual inspection, the digital rectal examination, DRE, is the next step. This is probably the most well-known part of the exam.
It is, and it provides crucial information. With sufficient lubrication, the index finger is gently introduced, often directed posteriorly initially to follow the curve.
Okay. What can you feel inside?
As the finger enters, you can feel the puborectalis muscle sling posteriorly, particularly at the apex of the canal. Higher up, above the pelvic floor muscles, you might feel supraelevator induration, a hard, often bony feeling area suggesting something abnormal, like a mass or a deep infection in that space. This is often more easily appreciated if it's unilateral. You can also palpate nearby organs in males, the prostate gland anteriorly, in females, potentially the cervix. And of course, you're feeling for any masses within the rectal wall, anal canal, or pressing on the canal from outside.
How do you assess the sphincter muscles with your finger during the DRE?
You assess the functional length of the anal canal enclosed by the sphincters. You feel the resting tone, which is mainly the involuntary internal sphincter,
Right.
and then ask the patient to squeeze and hold, assessing the voluntary squeeze increment, which reflects the external sphincter's function, and the puborectalis. This gives you a good indication of overall sphincter integrity and strength.
And as you withdraw the finger, what are you looking for then?
You inspect the finger for any mucus, pus, or blood, noting its color. The color and consistency of any stool on the finger can also provide clues about the patient's bowel function and any potential issues higher up in the colon.
The sources include a well-known saying about the digital exam.
Yes, the classic quote is, "If you don't put your finger in, you might put your foot in it."
Huh. Yeah, I've heard that.
It's a memorable way to emphasize that the DRE is a fundamental and often indispensable part of evaluating patients with anorectal symptoms, and skipping it can lead to misdiagnoses.
Okay. Beyond the DRE, instruments allow for direct visualization. Proctoscopy, for example.
Proctoscopy provides a clear visual inspection of the distal rectum and the entire length of the anal canal. It's typically performed with the patient in the same position as the DRE. Different types of proctoscopes are available, allowing for visualization along the entire 3 to 4 centimeter length.
And you can do minor procedures through it, like
Yep.
treatments.
Yes, it provides access for office-based procedures like injecting or banding internal hemorrhoids or taking biopsies of suspicious lesions within the anal canal.
Okay.
It can also be used dynamically by asking the patient to bear down as the proctoscope is slowly withdrawn. This maneuver can help identify conditions like descending into susception, a sort of telescoping of the upper rectum into the lower.
And sigmoidoscopy is mentioned as always necessary when assessing these symptoms.
Yes, sigmoidoscopy, whether using a rigid or flexible scope, is essential for examining the rectum itself. While it doesn't look at the entire colon, the sources emphasize that it must always be performed when evaluating anal symptoms because rectal pathology is frequently associated with anal conditions like fistulas originating from the rectum, or can be an independent cause of symptoms like bleeding or changes in bowel habit.
So it's a vital part of a complete assessment.
Absolutely. Can't skip it.
So the combination of visual inspection, DRE, and proctosigmoidoscopy provides a thorough clinical assessment of this region. Summary box 80.2 reinforces these points, including the necessity of DRE and proctosigmoidoscopy for anyone with bowel symptoms.
These are the fundamental steps that guide diagnosis in the vast majority of cases. It's the bread and butter.
Let's move from the clinical exam to how we objectively measure the function of the anal sphincters and pelvic floor in a more detailed way. The sources reiterate that continence and defecation are complex, involving multiple integrated systems.
They are indeed. It's a coordinated interplay between the central nervous system, autonomic and enteric nervous systems, the GI tract's ability to handle waste, especially rectal capacity and compliance,
Right.
the pelvic floor muscles, and the anal sphincter complex. A problem in any one area can disrupt this harmony.
How do you objectively assess the sphincter's function in, say, a lab setting?
This is typically done in specialized anorectal physiology laboratories. Techniques can quantify things like the position of the perineum at rest and how much it descends during straining, which provides insights into pelvic floor muscle and pudendal nerve function.
Okay.
Manometric techniques are a key part of this assessment.
What specifically can it tell us?
Okay.
Pressure measurements.
Exactly. Simple manometry measures the pressures within the anal canal using a specialized catheter. It can determine the functional anal canal length. That's the segment where resting pressure is higher than rectal pressure.
Uh-huh.
It measures the resting tone, which primarily reflects the internal sphincter's contribution, about 85%. And it measures the squeeze increment, the increase in pressure generated by a voluntary squeeze, reflecting the external sphincter and puborectalis function.
Okay, so resting and squeeze pressures.
Right. Figure 80.5 gives a conceptual look at a typical manometric tracing.
And you mentioned that crucial rectoanal inhibitory reflex earlier. Can manometry show that?
Yes, you can demonstrate the rectoanal inhibitory reflex manometrically. By distending the rectum with a balloon, you observe the characteristic reflex relaxation of the internal sphincter. As we discussed, this reflex is essential for allowing contents to contact the anoderm for discrimination. Figure 80.6 shows a tracing illustrating this reflex.
Okay. Beyond pressure, you can also visualize the structure of the sphincters using imaging.
Exactly. Endoluminal ultrasonography, or EAUS, is a key modality. A small ultrasound probe is inserted into the anal canal.
Right into the canal.
Yes. It provides high-resolution 2D images that can be reconstructed into 3D views. This allows detailed visualization of the sphincter complex, assessing their thickness and structural integrity, and identifying tears or defects like those sometimes seen after obstetric injuries. Figure 80.7a shows an example EAUS image.
MRI is also used for visualization, isn't it?
Yes, MRI offers excellent soft tissue differentiation. While the spatial resolution for the immediate sphincters might sometimes be slightly less detailed than EAUS when using a standard body coil, MRI is invaluable for assessing the entire pelvic floor region, identifying associated pathology, or mapping complex fistula tracts. Figure 80.7b shows an example MRI view.
To understand functional emptying problems, you sometimes need to see the act of defecation itself.
That's where evacuation proctography comes in. This is a radiological technique. Radio-opaque pseudostool, often a thick barium paste, is inserted into the rectum.
Yeah.
Real-time X-ray imaging, fluoroscopy, or dynamic MRI is used while the patient sits on a commode and is asked to rest, squeeze, and then evacuate the paste.
So you want your happen.
Pretty much. This allows assessment of the anorectal angle changes, how the rectum empties, and identification of functional issues like rectocilies, herniation of the rectum into the vagina, enterocles, herniation of small bowels, or intussusception of the rectal wall. Figure 80.8 shows examples of both barium and MR proctography.
And sometimes contrast is added elsewhere to see other structures.
Yes, oral contrast might be given to visualize the small bowel for enterocoles, and in women, a radiopaque vaginal tampon can help delineate the vaginal wall's position during defecation.
Oh,
Dynamic MR proctography can give more detail on other pelvic organs, but the sources note the supine position used in the scanner might be less physiological for evacuation than sitting on a commode, so there's a trade-off.
it sounds like these investigations provide really useful objective data, but the sources stress they must be used alongside the clinical picture.
Absolutely critical. Imaging findings must always be interpreted within the context of the patient's actual symptoms. You treat the patient, not just the scan. This helps guide rational, effective treatment strategies.
Okay, let's shift gears to some conditions, starting with those that arise from development congenital abnormalities. Briefly, how does the anal canal form embryologically?
Okay, so early in development, there's a single chamber called the cloaca, where the hindgut and urinary system open. A septum divides it. The anal canal forms when the lower end of the hindgut meets an invagination of the outer ectoderm, forming the anal membrane.
Right.
This membrane usually resorbs around 8 weeks of gestation, creating the connection to the outside.
So if that membrane doesn't resorb,
That leads to an imperforate anus, also called analogenesis or atresia. The anal opening is absent. Historically, these were classified as high or low based on the rectum's termination level relative to the pelvic floor. The severity and prognosis depend heavily on associated abnormalities, especially of the sacrum and genitourinary system.
what about a postinal dermoid cyst? What's that?
This is a soft cystic swelling located in front of the lower sacrum and coccyx. They can be quite hidden initially and often only come to attention in adulthood if a sinus connects it to the outside or if it gets infected, which is actually the most common presentation.
Okay.
Very rarely, if large, they can cause some difficulty with defecation. They are usually easily palpable on rectal examination.
What might it be mistaken for?
It can be confused with other midline masses or sinuses. An anterior sacral meningocele, especially if associated with a sacral bone abnormality, needs to be ruled out. Meningoceles can enlarge when a child cries and may be associated with neurological issues.
Important distinction.
Yes. And if there's a draining sinus, it might be mistaken for a pilonidal sinus or even an anal fistula.
How do you confirm a postgenital dermoid?
Well, pressing over the sacrococcygeal region while doing a rectal exam might cause sebaceous material to discharge if there's a sinus. Injecting contrast into a sinus and imaging can show a characteristic bottlenecked cyst.
And the treatment is surgery.
Yes, complete surgical excision of the cyst and any sinus is necessary. For large or presacral dermoids, removal of the coccygeals might be needed to ensure complete excision, partly due to the risk of associated sacrococcygeal teratoma in children. It's also vital to screen for a Currarino triad in patients with presacral masses and sacral malformations.
What's that triad?
It's an inherited condition involving sacral malformation, an anorectal anomaly or stenosis, and a presacral mass. Important to consider.
Got it. And a simple postinal dimple. Is that anything to worry about?
That's just a small dimple in the skin beneath the tip of the coccyx, sometimes a short blind pit. It's a normal incidental finding with no clinical significance, just a variation.
Let's move to pilonidal sinus, a common condition affecting the natal cleft. What is it exactly?
A pilonidal sinus is a chronic condition found in the crease between the buttocks, overlying the coccyx. It's characterized by one or more small midline openings in the skin that lead into a subcutaneous fibrous tract containing loose hair and lined by granulation tissue.
Is the debate over whether it's congenital or acquired settled? Are we born with it or does it develop?
The sources note that acquired theories are now much more widely accepted, though the precise mechanism is still debated.
What's the evidence for it being acquired?
Several points support this. Its appearance after puberty, its association with professions like hairdressers, they get them between their fingers, interdigital pilonidal sinus.
Oh, interesting.
Yeah. Also, the rare presence of hair follicles in the sinus walls. The fact that shed hairs are found pointing into the sinus, its prevalence in hirsute individuals, and its tendency to recur even after what seems like adequate treatment.
So, what are the theories for how it's acquired? How does the hair get in there?
Two main theories. One is that friction and shearing forces in the deep natal cleft literally cause shed or broken hairs to penetrate the midline skin, like drilling in.
Ouch.
The other is that infection starts in a hair follicle, and then the negative pressure or suction created by buttock movement during walking or sitting draws hairs and debris into the subcutaneous tissue, creating a chronically infected midline tract.
And secondary tracts often develop from that main one.
Yes, from that primary midline tract, Pus and debris can track outwards, often laterally, creating secondary openings on the skin away from the midline. The main midline sinus usually runs upwards, cephalad, towards the head, but can sometimes run downwards, which can cause confusion.
Is there a risk of cancer? The risk of carcinoma developing within a chronic pilonidal sinus is exceedingly rare. Very, very uncommon.
Who is typically affected by pilonidal sinus.
It's much more common in men, typically appearing after puberty and before the age of 40, particularly in those with dark, coarse body hair. Obesity and having a deep natal cleft are also risk factors.
What are the symptoms? What do people complain of?
Patients usually complain of intermittent pain, swelling, and discharge at the base of the spine. They usually don't feel generally unwell unless an acute abscess forms. There's often a history of previous abscesses in the area that may have burst or been drained.
On examination, what do you look for specifically?
You specifically look for the primary sinus openings, those small pits located strictly in the midline between the sacrococcygeal joint and the tip of the coccytake. Their location is key.
And if the openings are not in the midline or the drainage pattern is unusual, what should you think then?
That's a crucial point from the sources. If you don't find primary midline pits, or if the drainage is lateral to the sacrum or appears to track downwards towards the anus, you must consider other diagnoses.
Like what?
Like hidradenitis suppurativa, a complex anal fistula, osteomyelitis of the sacrum, or specific infections like tuberculosis. Need to broaden the differential.
How is pilonidal sinus treated?
Treatment depends on the severity and whether it's acute or chronic. The sources note that many mild cases, or those with minimal symptoms, may eventually resolve on their own. Conservative management for mild symptoms includes keeping the area clean, free of hair, using exfoliation, and strict hygiene.
Okay.
Local techniques like cauterizing the tracts with silver nitrate or laser can be tried for less extensive disease.
If an acute abscess forms, just drain it.
Drainage is the essential first step, yes. This involves making an incision over the most prominent part of the abscess, ideally slightly off the midline to aid drainage, and thoroughly cleaning out any pus, granulation tissue, and hairs. Drainage alone can sometimes lead to complete resolution.
For chronic disease, surgery is common. But the sources mention a wide variety of procedures. What does that imply? Why so many options?
The existence of a multitude of surgical procedures listed in the sources suggests that no single method is universally superior or has proven dramatically better than all others in all situations. The choice of procedure often depends on factors like the extent of the disease, the desired time off work for the patient, recurrence rates associated with the technique, and frankly, the surgeon's familiarity and preference.
What are the general principles of surgical management then? What are the main approaches?
Options range from simply laying open all the sinus tracts, sometimes marsupializing the edges, suturing them open to reduce the wound size and speed healing.
Okay.
Another approach is to excise or cut out the entire disease process, the midline pits and tracts, and then either leave the wound open to heal from the bottom up, healing by secondary intention, or close the wound primarily, suturing it shut.
Yeah, techniques designed to avoid a midline closure. You mentioned those are becoming more popular.
Yes, these are increasingly favored for more extensive disease or chronic cases, as a midline wound in the deep natal cleft can be prone to poor healing due to tension, moisture, and friction. Techniques like the Limburg flap, Caridocus procedure, or Z-plasty involve excising the diseased area and then bringing a flap of healthy skin and subcutaneous tissue from the buttock laterally to close the defect off the midline.
Ah, clever.
The idea is to flatten the natal cleft and move the suture line away from the area of maximum stress and moisture.
The sources also detail Bascom's procedure specifically.
Bascom described an approach involving making a lateral incision parallel to the natal cleft to access and clean out the subcutaneous cavity, removing hair and granulation tissue. Critically, he advocates for excising and closing the midline pits that allowed the hairs to enter in the first place. The lateral wound is often left open to heal secondarily. Figure 80.9a illustrates this technique. For failures or recurrences, a more extensive cleft lift or flap procedure, also described by Bascom, might be needed.
It's emphasized for postoperative care. What's most important after surgery?
Rigorous hair removal from the wound area, regardless of the technique used, is highlighted as crucial for successful healing and preventing recurrence.
Keep the hair away.
Exactly. The sources also note that while leaving wounds open to heal, secondary intention, may have lower reported recurrence rates, healing times are generally slower than with primary closure. And for primary closure, off-midline techniques tend to have lower recurrence rates and faster healing than closing the wound directly in the midline.
Now let's turn our attention to a complex issue. Incontinence, specifically fecal incontinence.
Okay.
This feels like a challenge involving many more systems than just the local anatomy we've been discussing.
It absolutely is. Maintaining continence requires a sophisticated interplay involving intact neurological pathways from the brain down to the sphincters, a properly functioning gastrointestinal tract capable of storing stool rectal capacity and compliance are key here,
Right.
effective pelvic floor muscles, and a competent anal sphincter complex. A problem in any of these areas can lead to loss of control. It's multifactorial often.
The sources list a wide range of potential causes and risk factors in Table 80.1.
Yes, it's an extensive list. Congenital causes include anorectal malformations or spinal defects like spina bifida. Acquired causes are very broad. Age-related changes, neurological conditions like stroke, Parkinson's, MS, spinal cord injuries, systemic diseases like diabetes or scleroderma, inflammatory bowel disease, Crohn's, ulcerative colitis, conditions affecting rectal emptying like rectal prolapse or rectocele, pelvic floor dyssynergia, and most significantly, prior damage.
Prior damage from what? What causes the damage typically?
Damage to the sphincter muscles or their nerve supply. This is very commonly caused by obstetric events, particularly difficult or complicated vaginal deliveries resulting in sphincter tears or nerve stretch injuries. That's pudendal neuropathy.
Childbirth injury.
Very common cause. Prior anal surgery for conditions like fissures, sphincterotomy, especially if uncontrolled, hemorrhoids, hemorrhoidectomy, especially aggressive ones or historical dilations, or fistulas, fistulotomy, dividing too much muscle, are also significant risk factors. Trauma, including anal intercourse, can also cause injury.
And incontinence can occur after major bowel surgery higher up, like for cancer.
Yes, operations that remove or significantly shorten the rectum, such as low anterior resection or colonal anastomosis for rectal cancer, can lead to incontinence symptoms, often part of what's called low anterior resection syndrome, or LARS.
LARS.
Yeah. It's due to loss of rectal storage capacity and disruption of nerves. Radiation therapy to the pelvis can further exacerbate these functional issues.
The sources state clearly that fecal incontinence is a symptom, not a diagnosis itself.
That's a critical point. You can't just treat incontinence. You must identify the underlying cause or combination of causes. A comprehensive history detailing the type and severity of symptoms, past medical, surgical, and obstetric history, combined with a thorough clinical examination, including sigmoidoscopy or colonoscopy, is the starting point.
One common, often treatable cause mentioned is fecal loading or impaction, especially in the elderly.
Yes, this occurs when a large, hard mass of stool obstructs the rectum and liquid stool leaks around it. This is called overflow incontinence. It's usually easily diagnosed by digital rectal examination and managed by clearing the impaction and preventing recurrence through bowel regimen management.
When it's not overflow from impaction, what are the other main mechanisms causing incontinence?
The sources list 3 key mechanisms which can occur alone or together. First, loose or urgent stool that's simply difficult to contain even with intact sphincters. Second, reduced rectal volume or compliance, meaning the rectum can't store much or accommodate volume changes effectively. And third, anatomical or functional injuries to the sphincter complex itself.
And sphincter causes can be structural damage, like tears, or nerve damage.
Exactly. Structural causes are physical disruptions to the sphincter muscles, such as tears, common after childbirth, surgical division, or muscle atrophy over time. Neuropathic causes involve damage to the nerves supplying the sphincters, often the pudendal nerve, which can be stretched or injured during childbirth or chronic straining. Often, both structural and nerve damage coexist.
What investigations are used to objectively assess these issues? We talked about manometry and imaging before.
Yes, anorectal physiology studies are key. Manometry measures resting tone, internal sphincter, and squeeze pressure, external sphincter, giving a quantitative assessment of function. EAUS, the endoanal ultrasound, is vital for imaging the sphincter muscle's structural integrity, allowing identification and precise location of tears or defects. These are very common causes after vaginal delivery, as shown in figure 80.11.
Okay.
Defecography, standard X-ray or MRI, is used less routinely but can be helpful if symptoms include a mix of incontinence and emptying difficulties or prolapse.
How is fecal incontinence managed? What are the options?
The sources emphasize that the majority of patients can be successfully managed with conservative measures. These include dietary advice, avoiding triggers for loose stools, using stool bulking agents or constipating medications to improve stool consistency, using cleansing enemas or rectal irrigation to ensure the rectum is empty at predictable times.
Right, planned emptying.
Exactly. And nurse-led bowel retraining programs that often include biofeedback, helping patients learn to optimize muscle control. Anal plugs, essentially barriers, can also be used in some cases.
If conservative measures fail or for severe symptoms, surgery is considered. What are the surgical options for the sphincter itself, if there's a tear?
If there's a discrete, identifiable tear in the sphincter muscle, often from obstetric injury, a direct repair can be attempted. The Parkes overlap repair is a common technique where the divided ends of the muscle are identified and sewn together in an overlapping fashion. Figure 80.12 illustrates this.
Does it work well long term?
It can lead to significant short-term improvement, but the sources note that the degree of improvement may lessen over 5 to 10 years.
The sources mentioned pelvic floor repairs are largely historical now.
Yes. Procedures like postanal or preanal repairs are rarely performed today as results haven't been as good as other approaches. For more severe sphincter dysfunction where direct repair isn't feasible or has failed, sphincter reconstruction techniques like muscle transposition have been explored.
Using other muscles.
Right. This involves detaching another muscle, like the gracilis muscle from the thigh, or a part of the gluteus maximus, and wrapping it around the anal canal to try and function as a sphincter.
And stimulated muscle transposition. You mentioned that too.
Yes, that involves implanting a pacemaker to electrically stimulate the transposed muscle, for example, dynamic graciloplasty, to convert it into a slow twitch muscle capable of maintaining continuous tone, as conceptually shown in figure 80.16. While results were initially promising, long-term success has been limited. Historically, artificial sphincters were also implanted, but are no longer commercially available.
What about injecting materials to augment the sphincter? Bulking agents.
Yes, injectable biomaterials are used to add bulk to the anal canal, aiming to narrow the lumen and improve the sealing mechanism. Various biocompatible materials have been tested. A more recent approach, like the SpinKeeper device, involves implanting self-expanding prostheses radially within the intersphincteric space to provide structural augmentation to the sphincter complex, as shown in the EAUS image in figure 80.13.
A relatively newer, significant development discussed is sacral nerve stimulation, or SNS.
SNS is a form of neuromodulation. It involves implanting electrodes near the sacral nerve roots, usually S3 or S4, which control bowel and bladder function. Low-voltage electrical stimulation is delivered to these nerves.
Like a pacemaker for the bowel nerves.
Kind of, yeah. It's thought to augment continence by activating autonomic sensory pathways. It's been particularly effective in patients with symptoms suggestive of pelvic neuropathy, common after childbirth. Figure 80.14 shows electrode placement, and figure 80.15 shows a radiograph of an implanted system.
How does it work? Is there a trial period?
Yes. The process involves a temporary screening phase, usually a couple weeks with external wires, to assess responsiveness before permanent implantation of the neurostimulator device under the skin.
How successful is SNS?
The sources indicate it offers sustainable, long-term symptom improvement for many patients. It has relatively low complication rates compared to major surgery, although issues like infection or loss of efficacy can occur, sometimes requiring device removal.
Any other neuromodulation techniques?
Percutaneous posterior tibial nerve stimulation, PTNS, a less invasive form stimulating the tibial nerve in the ankle, is mentioned as a less expensive option with more modest outcomes.
The sources note that despite these options, management often relies on expert opinion within a team.
That highlights the complexity of incontinence and the need for individualized care. The evidence base for some treatments isn't as robust as we might like, so management within a multidisciplinary team is often the standard, tailoring treatment to the specific causes and the patient's goals and expectations.
And for the most severe end-stage cases that don't respond to other treatments, what's the last resort?
An end stoma, such as a colostomy, is an option. While acknowledging the significant psychosocial adjustments and potential complications, the sources point out that for patients with severe refractory incontinence, a stoma can dramatically improve their quality of life, restoring predictability and allowing them to resume normal activities. It's a valid option in those difficult cases.
Let's move to anal fissure, a very common but often intensely painful condition. What is it anatomically?
An anal fissure is defined as a longitudinal ulcer, basically a tear in the anoderm, that specialized lining of the distal anal canal. Figure 80.17 shows its typical appearance. It usually extends from the anal verge upwards, but typically stops at or just below the dentate line.
The source says the exact cause isn't fully known, particularly why the posterior midline is the most common location. Any theories?
There are theories, yes. The posterior midline may be subjected to greater shearing forces during the passage of stool. The anoderm in this area might be less elastic or have a poor blood supply. There's also thought to be an increased concentration of longitudinal muscle extensions inserting posteriorly, which might make the area less yielding.
Oh, okay.
Anterior fissures are less common, more often seen in women, and can be associated with vaginal delivery.
And the sources describe a classic vicious cycle that perpetuates fissures. Can you explain that?
This is a really key concept for understanding fissures. Many patients with anal fissures have underlying hypertonia of the internal anal sphincter. The involuntary muscle is too tight.
Spasm.
Exactly, spasm. This increased tone constricts the anal canal, making the lining more vulnerable to trauma from hard stool. The initial tear occurs, causing pain. The pain itself then reflexively increases the internal sphincter tone further, tightening the canal, reducing blood flow to the area that's ischemia, and making the passage of subsequent stool even more difficult and traumatic.
So it just keeps going.
Right. This cycle of pain, sphincter spasm, ischemia, and repeated trauma prevents healing and leads to a chronic, deep ulcer.
What are the typical symptoms of an anal fissure? How does it feel?
For an acute fissure, the hallmark is excruciating pain during or immediately after defecation. Patients often describe it vividly, like passing glass or a knife cutting.
Wow.
The pain typically lessens but can recur with the next bowel movement. There's usually a small amount of fresh, bright red blood on the toilet paper, unlike the splash sometimes seen with hemorrhoids.
And how do chronic fissures present? Do they look different?
Chronic fissures are characterized by their appearance. Due to repeated cycles of healing and breakdown, they often develop characteristic features. A hypertrophied anal papilla inside the anal canal, a thickened bump at the dentate line, and an external skin tag, called a sentinel tag, at the anal verge.
Okay.
The ulcer base is typically indurated, hardened, and may expose the white fibers of the internal sphincter. Patients might also complain of itching due to irritation from the sentinel tag or discharge from the ulcer.
Can fissures occur at any age?
Yes, from infants to the elderly, but they are most common in young adults.
The sources strongly warn about atypical fissures. What makes a fissure atypical, and why is that important?
An atypical fissure is one that is not located in the classic posterior or anterior midline position, or one that has unusual features like irregular, undermined, or excessively indurated edges, or doesn't have the typical clean ulcer base.
Okay.
Finding an atypical fissure should immediately raise suspicion for an underlying specific cause other than simple trauma and sphincter hypertonia. It's a red flag.
What kind of specific causes should you think of?
Conditions like Crohn's disease, tuberculosis, sexually transmitted infections like syphilis, herpes simplex, HIV-related ulcers, or even squamous cell carcinoma of the anal canal can present with an atypical fissure.
So it could be something much more serious.
Exactly. If a standard clinical examination is too painful to be adequate, examination under anesthesia with biopsy and culture of the lesion is essential to rule out these more serious or specific conditions.
How are anal fissures treated? What's the first step?
Conservative management is the first-line treatment and is successful for the vast majority of acute and most chronic fissures. The goal is to break that vicious cycle we talked about.
What does conservative management involve?
Primarily, normalizing bowel habits to avoid hard stools using dietary fiber, stool softeners, and adequate fluid intake. Warm sitz baths can help relax the sphincter and soothe pain. Topical local anesthetics provide temporary pain relief. Biofeedback can help patients who have poor bowel habits or excessive straining.
And the mainstay of modern conservative therapy is chemical sphincterotomy, using creams or ointments.
Yes, this uses pharmacological agents applied topically to relax the hypertonic internal sphincter. Glycerol trinitrate, or GTN, 0.2% ointment is a common option. It's a nitric oxide donor, and nitric oxide causes smooth muscle relaxation.
Nitric oxide again.
Yeah. Applied 2-3 times daily, it reduces sphincter tone, improves blood flow, and promotes healing. However, headache is a very common and limiting side effect for many people.
Are there alternatives to GTN that avoid the headaches?
Yes, calcium channel antagonists like diltiazem 2% ointment, applied twice daily, also reduce internal sphincter tone with fewer systemic side effects than GTN.
Okay.
Botulinum toxin Botox can also be injected directly into the internal sphincter. It blocks acetylcholine release at the nerve ending, causing temporary muscle paralysis and pressure reduction.
Botox for fissures.
Yeah.
Interesting. Any downsides?
While effective, there's a reported temporary risk of incontinence to gas or liquid in up to 10% of patients after Botox injection.
How do these chemical treatments compare in effectiveness?
GTN has a cure rate around 50%, limited by headaches. Botulism and botulinum toxin offer similar healing rates, but are generally better tolerated in terms of systemic side effects, although Botox carries that temporary incontinence risk. Summary Box 80.4 outlines these conservative approaches nicely.
If conservative measures fail, surgical options are considered. The source had mentioned anal sphincter dilatation. Is that still done?
Anal sphincter dilatation, a forceful stretching of the sphincter under anesthesia, was historically used but is now rarely indicated. The risk of causing uncontrolled, multiple sphincter disruptions and subsequent incontinence is just too high compared to safer, more targeted surgical options available now.
So the primary surgical option for chronic fissures that don't heal conservatively is lateral anal sphincterotomy.
Cutting the muscle.
Yes, it's a controlled surgical division of the internal sphincter muscle performed in the lateral position, usually left or right away from the fissure itself. The aim is to reduce the hypertonia and pressure within the canal to the level of a normal sphincter, thereby improving blood flow to the fissure and allowing it to heal.
How is it performed? Is it a big operation? It can be done using an open or closed technique under local, regional, or general anesthesia, often as a day case. In the closed method, a small incision is made over the intersphincteric groove, and the internal sphincter is identified and precisely divided using scissors or a knife up to the level of the fissure apex. Figure 80.18 illustrates a scissor technique. The small skin wound is usually closed. The open technique involves incising the overlying anoderm to expose the sphincter before dividing it.
Does the fissure itself need attention during the surgery? Do you cut out the fissure?
The source notes that the fissure ulcer typically doesn't need to be excised, as it should heal once the sphincter hypertonia is relieved. However, any associated hypertrophied anal papilla or sentinel tag can be excised if they're causing symptoms.
What are the outcomes and risks of lateral sphincterotomy? High success rate.
Healing rates for the fissure are high, around 85%. However, the main risk, and it's a significant one, is altered continence. The sources cite rates around 9% for flatus incontinence, 6% for minor soiling, and less than 1% for incontinence to solid stool.
That's not insignificant.
No. The amount of sphincter divided is crucial and debated, and may need to be tailored based on patient factors like age, sex, and prior obstetric history to minimize the risk of compromised incontinence while achieving healing. It's a balance.
Are there other surgical options besides sphincterotomy, maybe ones that preserve the sphincter?
The hysterectomy involves surgically excising the fibrotic edges of the chronic fissure and curating the base, sometimes excising the tag and papilla. It's an option if sphincterotomy is contraindicated, for example, in a patient with already low sphincter tone. It's often combined with an anal advancement flap.
Tell me about the anal advancement flap. That sounds sphincter preserving.
It is. This is a technique often considered for fissures, particularly in patients at higher risk of incontinence after sphincterotomy, such as women who have had difficult deliveries or individuals with normal or low baseline sphincter pressures. After excising the fissure, fissurectomy, a flap of healthy perianal skin, typically shaped like an inverted house and based on its blood supply, is carefully mobilized. Figure 80.19 diagrams this. This flap is then advanced upwards without tension to cover the defect left by the fissure excision and sutured in place.
So you cover the wound with healthy tissue.
Exactly. Patients are kept on stool softeners post-operatively. The source notes that minor breakdown of a suture line edge doesn't necessarily mean the entire flap has failed. Summary Box 80.4 lists these operative treatments too.
You mentioned hypertrophied anal papillae earlier. Are they always symptomatic or only if associated with a fissure?
Anal papillae are normal remnants at the dentate line found in most people. They can become elongated, especially with chronic irritation like a fissure. While often asymptomatic, an elongated papilla can cause pruritus, or itching. In infants, they can cause pain or bleeding. Rarely, hemorrhage into a papilla can cause sudden, severe rectal pain.
And cryptitis, what's that?
The sources also describe cryptitis, which is inflammation and infection of an anal gland and its associated papilla. This causes local pain, a red swollen papilla, and sometimes purulent discharge. Treatment involves laying open the mouth of the infected gland and excising the inflamed papilla. Troublesome papillae that cause symptoms can be surgically excised.
And finally, another painful condition mentioned is proctalgia fugax. Sounds dramatic.
It can feel dramatic for the patient. It's a condition characterized by recurrent, sudden onset, severe cramp-like pain in the rectum. The attacks are typically short-lived, lasting minutes, often occur at night, and resolve spontaneously. Importantly, it's not related to any identifiable structural disease.
Any idea what causes it?
It's thought to be more common in anxious or stressed individuals and may be caused by a cramp in the pubococcygeus muscle. For acute attacks, an inhaled bronchodilator like salbutamol has been reported to provide relief. Medications like amitriptyline can be used to try and reduce the frequency of attacks.
The sources mention a chronic form called levator syndrome.
Yes, this is a more chronic form of persistent or frequent rectal pain, often associated with symptoms of difficulty emptying the bowels or evacuatory dysfunction. Biofeedback techniques are often used to help manage levator syndrome.
Let's move on to hemorrhoids, probably the most widely recognized anal condition. What are they, anatomically speaking?
Hemorrhoids, also known commonly as piles, are defined as symptomatic enlargements of the internal hemorrhoidal venous plexus. The name comes from the Greek word meaning blood flowing. Figure 80.20 shows an example image of what are called mixed hemorrhoids.
They're located in specific positions, classically.
Yes. Classically, the primary hemorrhoids develop in the 3, 7, and 11 o'clock positions when the patient is examined in the lithotomy position that's on their back with legs elevated. Secondary hemorrhoids can form between these primary positions.
And there's a distinction between internal and external hemorrhoids, right?
Yes. Internal hemorrhoids arise from the internal hemorrhoidal plexus, which is located above the dentate line in the submucosa. These form the submucosal component of the anal cushions, which are important structures for sealing the anal canal.
Okay.
True external hemorrhoids arise from the external hemorrhoidal plexus below the dentate line in the perianal skin, but the term external hemorrhoid in common usage often refers to a thrombosed external hemorrhoid or just an anal skin tag, neither of which are strictly hemorrhoids by this definition. We're primarily focusing on internal hemorrhoids here.
Why do people get hemorrhoids? What causes them?
Several factors are thought to contribute. Man's upright posture and the absence of valves in the portal venous system are mentioned as background factors. The key driver is thought to be chronically raised abdominal pressure, commonly caused by straining during defecation, pregnancy, or lifting heavy weights. This increased pressure leads to engorgement and swelling of the veins in the hemorrhoidal plexus, essentially forming varicosities within these cushions.
And how does it progress from just engorgement?
With continued straining and engorgement, shearing forces can cause the overlying mucosa to be traumatized, leading to bleeding. The supporting tissues weaken, causing the vascular cushions to be displaced downwards. This is prolapse.
Right.
Impaired venous drainage from chronic engorgement leads to local stasis, fluid transudation or leakage, and often pruritus or itching. And those age-related changes in the supporting fibroelastic tissue we discussed earlier also contribute to the loss of elasticity, preventing the cushions from retracting properly after defecation, which worsens prolapse.
What are the typical symptoms of internal hemorrhoids? Bleeding is common.
Bleeding is often the earliest and most common symptom. It's typically painless and occurs with defecation, appearing as bright red blood on the toilet paper or as a splash in the toilet bowl, usually separate from the stool itself.
Bright red because of those AV shunts.
Exactly. While usually not severe, chronic bleeding can rarely lead to iron deficiency anemia, but other causes of bleeding must always be excluded first. Pruritus is common due to mucus discharge. Pain is not a typical symptom of uncomplicated internal hemorrhoids. If pain is present, it strongly suggests another diagnosis, like an anal fissure or a thrombosed external hemorrhoid.
Patients also complain of lumps or
Yeah.
things coming down.
Yes, this is the prolapse. Hemorrhoids are graded based on the degree of prolapse.
Bleed only. They don't prolapse outside the anal canal.
Okay.
Second degree. Prolapse out during defecation, but spontaneously reduced back inside afterwards.
Right.
Third degree. Prolapse out during defecation, but require manual reduction pushing them back inside to go back in. Figure 80.20 conceptually shows third-degree prolapse
Got it.
and fourth degree are permanently prolapsed outside the anal canal and cannot be reduced.
The sources also mention mixed hemorrhoids, which have a significant component below the dentate line, essentially external extensions of the internal piles caused by repeated congestion and swelling. Summary boxes 80.5 and 80.6 cover these features and the grading.
Correct.
What are the potential complications of hemorrhoids? Can they get worse?
Strangulation and thrombosis are uncommon but very painful complications. This occurs when prolapsed hemorrhoids become trapped outside the anal canal by the tight external sphincter, leading to severe swelling, pain, and potential tissue death or necrosis.
Ouch! How is that managed?
It needs to be distinguished from rectal prolapse or a simple thrombosed external hemorrhoid first. Management often starts conservatively with pain relief, bed rest, cold compresses, and laxatives, as resolution typically occurs within 3 or 4 days. Urgent hemorrhoidectomy can be performed to relieve the strangulation and speed resolution, but it requires careful technique to avoid causing anal stenosis later. Systemic antibiotics are often prescribed to reduce the risk of portal pyemia, a serious infection spreading via the portal vein.
Severe hemorrhage is another possibility. Significant bleeding.
Yes, though less frequent than bleeding from fissures. If severe bleeding occurs, first rule out any bleeding disorders or anticoagulant use. Local pressure with an adrenaline-soaked compress often stops the bleeding. If blood loss is significant, transfusion might be needed.
Okay.
After stabilizing the patient, examination under anesthesia might be required to ligate or excise the bleeding hemorrhoids, or specifically secure a bleeding point with diathermy or suture ligation. If no obvious bleeding point is found, anal packing might be necessary. Summary box 80.7 lists other rare complications like ulceration, gangrene, and portal pyemia.
How is hemorrhoidal disease managed overall? What's the first step?
The absolute first priority when a patient presents with rectal bleeding is to exclude other, more serious causes, especially colorectal malignancy, through appropriate examination and endoscopy. Cannot stress that enough.
Rule out the bad stuff first.
Always. General measures then focus on lifestyle and bowel habits. Improving diet to ensure soft formed stools, adopting a position that minimizes straining during defecation, like using a footstool, using stool softeners and bulking agents. Various proprietary creams and suppositories are available. Some contain compounds intended to improve vascular tone or reduce inflammation, but their effectiveness can vary.
For first and second degree internal hemorrhoids not responding to these general measures, non-operative treatments are used, right? Like injections.
Rejection sclerotherapy is one method. A sclerostin solution, commonly 5% phenol in oil, is injected into the submucosa at the apex of the hemorrhoid pedicle, not into the hemorrhoid mass itself. Figure 80.21 shows the injection site.
Okay.
The aim is to induce fibrosis and scarring, which obliterates the vessels and fixes the mucosa to the underlying muscle, reducing prolapse and bleeding. Injecting too superficially or deeply can cause pain or complications.
The sources state that rubber band ligation has largely replaced sclerotherapy. How does that work?
Yes. Rubber band ligation, often performed using a Barron's bander, is a widely used and effective office procedure for first and second degree hemorrhoids. Figure 80.22 shows the equipment and a banded hemorrhoid.
Okay.
The key is to grasp the hemorrhoid and slip a tight elastic band onto its base, ensuring the band is placed above the dentate line. This is crucial because the tissue above the dentate line lacks somatic pain fibers, so the procedure is relatively painless. If placed below the dentate line, it would cause intense pain.
What happens after the banding? Does the hemorrhoid just fall off?
Essentially, yes. The band cuts off the blood supply, leading to ischemic necrosis. The banded tissue swells off within about 7 to 10 days, which can be associated with some bleeding, so patients need to be warned about this. The resulting scar tissue helps anchor the remaining anal cushion and prevents further prolapse. Often, all primary hemorrhoids can be treated in one session, or repeat treatments can be performed later.
Other ablative techniques like cryotherapy and infrared photocoagulation are mentioned but noted as less common.
Correct. Banding and sclerotherapy remain the main non-operative strategies.
When is surgery indicated for hemorrhoids? For the more severe cases?
Surgical excision, or hemorrhoidectomy, is typically indicated for third and fourth degree hemorrhoids, second degree hemorrhoids that haven't responded to non-operative treatment, mixed hemorrhoids with a significant symptomatic external component, or bleeding severe enough to cause anemia despite other measures.
Okay.
The sources note these indications are relative, and the goal is symptom improvement, recognizing that surgery carries risks. If the diagnosis is uncertain, examination under anesthesia with endoscopy is recommended before surgery.
What are the main surgical techniques for hemorrhoidectomy? There are a couple of standard ways.
The two most common conventional techniques are the open technique, like the Milligan-Morgan operation prevalent in the UK, and the closed technique, like the Ferguson procedure common in the USA.
Describe the Milligan-Morgan open technique. How's that done?
Under anesthesia, often after injecting dilute adrenaline for pain and vasoconstriction, the hemorrhoid is grasped with forceps. A V-shaped cut is made through the skin below the hemorrhoid, and the tissue is dissected upwards, separating the hemorrhoid from the underlying internal sphincter, which is kept visible to avoid damage. Figure 80.23 illustrates the steps. The vascular pedicle at the apex is ligated with the suture, the hemorrhoid is excised distal to the ligature, and any bleeding points are secured. Crucially, the resulting wounds between the excised areas are left open to heal by secondary intention, leaving bridges of healthy mucocutaneous tissue to prevent stenosis.
And the Ferguson or closed technique, how does that differ?
In the closed technique, the hemorrhoid and the overlying mucosa and skin are excised together. The pedicle is ligated, and then the defect is closed with a continuous suture. Figure 80.24 shows the wound closure. Each hemorrhoid is treated similarly, taking care to leave adequate tissue bridges between the excised areas to prevent later narrowing of the anal canal. So the main difference is closing the wound versus leaving it open.
Stapled hemorrhoidopexy, or PPH, is a different approach introduced by Longo. How does that work? It doesn't remove the hemorrhoids.
Correct. It doesn't excise the hemorrhoid masses themselves. Stapled hemorrhoidopexy uses a circular stapler inserted into the anal canal above the dentate line. It excises a ring of mucosa and submucosa containing the feeding vessels while simultaneously stapling the upper edge of the mucosa to the lower edge. Figure 80.25 shows the principle. This effectively lifts and reduces the prolapsed hemorrhoidal tissue, sort of pulling it back up.
What are the advantages and disadvantages of stapling compared to cutting them out?
Its main advantage is generally less postoperative pain and quicker recovery compared to conventional excision hemorrhoidectomy. However, the sources highlight important disadvantages. Higher recurrence rates than conventional surgery, persistence of external hemorrhoids, and potential for serious complications, including staple line dehiscence, breakdown, infection, and fistula formation. A distressing new symptom of tenesmus, a constant urge to defecate, can occur due to the presence of staples and may require reoperation. The sources emphasize that counseling and shared decision-making are essential when considering stapling, allowing the patient to weigh the faster recovery against the higher recurrence risk and potential for complications.
Transanal hemorrhoidal ligation, or HAL, is another technique mentioned. Doppler-guided.
Yes, HAL, sometimes combined with mucopexy, is a Doppler-guided technique. A probe inserted into the anal canal uses Doppler ultrasound to locate the feeding arteries supplying the hemorrhoids.
Finds the artery.
Exactly. These arteries are then ligated, tied off with sutures, reducing blood flow and causing the hemorrhoids to shrink. Mucopexy involves stitching the prolapsed tissue upwards. It's used for second and third degree hemorrhoids.
How does it compare?
Trials have shown lower recurrence rates compared to banding, but higher recurrence than conventional surgery. It generally has lower pain and complication rates compared to conventional hemorrhoidectomy. Summary box 80.8 provides an overview of these treatment options.
What's the typical post-operative care after hemorrhoid surgery? What should patients expect?
Hemorrhoidectomy is often performed as a day case procedure. Post-operative care includes warm sitz baths several times daily, taking bulk laxatives or stool softeners to ensure soft bowel movements and appropriate pain relief. Some surgeons prescribe a few days of oral metronidazole to help with pain and reduce infection risk. Follow-up typically involves a rectal examination a few weeks later to assess healing and check for any narrowing. If stenosis is detected, patients might be encouraged to use an anal dilator. And what are the potential complications after hemorrhoid surgery?
Complications can be early or late. Early complications include pain, urinary retention, especially in men, potentially requiring temporary catheterization and reactionary hemorrhage within the first 24 hours. Bleeding right after surgery.
Yes, reactionary bleeding is more common than secondary bleeding and may require returning to the operating room to find and ligate the bleeding vessel or pack the anal canal.
And late complications.
Late complications include secondary hemorrhage, which usually occurs around 7-10 days after surgery when the tissue slews, and, if severe, requires management under anesthesia. Anal stricture or narrowing is a serious complication to be prevented. If it occurs, regular dilatation or surgery, anoplasty may be needed. Other late issues include anal fissures or submucous abscesses. Incontinence can occur if there was inadvertent damage to the internal sphincter during the procedure. Summary box 80.9 lists these complications.
Finally, let's loop back to external hemorrhoids as the sources define them, the perianal hematoma.
Yes, the term external hemorrhoid clinically often refers to a thrombosed external hemorrhoid, also known as a perianal hematoma. This relates anatomically to the veins of the superficial or external hemorrhoidal plexus located beneath the perianal skin right at the anal margin.
How does a thrombosed external hemorrhoid present? Is it sudden?
Yes, it's characterized by the sudden onset of a painful, firm, bluish, olive-shaped subcutaneous swelling right at the anal margin. It's typically caused by a sudden increase in pressure, like straining during defecation, coughing forcefully, or lifting heavy weights. It commonly occurs in a lateral position. Figure 80.26 shows a ruptured one.
How is it managed? Can you treat it in the office?
If the patient presents within the first 48-72 hours of onset, the clot can often be evacuated under local anesthesia by making a small incision over the swelling and squeezing out the clot. This usually provides rapid pain relief.
What if it's left untreated? Does it go away on its own?
Untreated, a thrombosed external hemorrhoid can resolve on its own, although this can take several days or weeks and be quite painful. It can also become infected, separate rupture spontaneously allowing the clot to extrude or thrombose further. Often it resolves but leaves behind a small skin tag. The sources note that the majority of untreated cases either resolve completely or result in fibrosis and a skin tag.
Moving on to pruritus ani, that chronic, often maddening itching around the anus. What are the common culprits? Why does it happen?
Perianal ani is intractable itching of the skin around the anus. It's a common, embarrassing condition. The affected skin can appear reddened, thickened, hyperkeratotic, cracked, and moist. The causes are numerous, and finding the specific cause is key to treatment.
What are some of the possibilities the sources list?
Common causes relate to hygiene, either poor cleaning leaving irritants, or excessive cleaning with harsh soaps, or vigorous wiping which damages the skin barrier.
Too clean or not clean enough?
Exactly. Moisture from discharge due to other anorectal conditions like fissures, fistulas, or prolapsing hemorrhoids is a frequent cause. Parasites, particularly threadworms, Enteropes formicularis, are a very common cause, especially in children and their families.
Ah, threadworms.
Yes. Various dermatological conditions can also affect the perianal skin, including allergies to soaps, perfumes, laundry detergent, psoriasis, lichen planus, and lichen sclerosus.
And the sources include a crucial warning about ruling out something more serious, even with just itching.
This is vital. Any persistent or atypical itching must prompt careful examination to ensure it's not masking a neoplastic process, precancerous changes or malignancy.
Cancer presenting as itching.
Yes. Anal squamous cell carcinoma, malignant melanoma, anal intraepithelial neoplasia, AIN3, previously called Bowen's disease, and extramammary Paget's disease can all present with itching. Itching from a serious underlying condition can be subtle and delay diagnosis, so vigilance is necessary.
How is pruritus ani managed then?
Treatment focuses on addressing the underlying cause if one is identified. For example, treating threadworm infection with antiparasitic medication, or managing an underlying skin condition with specific creams.
Symptomatic treatment is also key, regardless of cause, right? To soothe the skin and break the itch-scratch cycle.
Absolutely. What does symptomatic treatment involve?
Dietary changes to ensure soft-formed stools are helpful, as this facilitates easier cleaning. Hygiene is paramount, but it's about gentle hygiene. Using cotton wool or moist toilet tissue instead of dry paper, washing the area with water alone, avoiding soap, and gently patting the area dry afterwards. Wearing cotton underwear helps keep the area dry. Barrier creams containing ingredients like calamine lotion or zinc oxide can protect the skin.
And if there's clear dermatitis?
If there's associated perianal dermatitis, a mild topical hydrocortisone cream, 0.5% or 1%, is often beneficial for short periods to reduce inflammation. Summary box, 80-point moan, lists common causes and treatment principles.
Let's delve into anorectal abscesses. What exactly are they and where do they usually come from?
Anorectal abscesses are acute collections of pus in the tissue surrounding the anus and rectum. They are common, more frequent in men, and represent an acute infection or sepsis. The most widely accepted theory for their origin, proposed by Parks, is the cryptoglandular theory.
The anal glands again?
Yes. This posits that the infection starts in one of the intersphincteric anal glands located in the intersphincteric plane between the two sphincter muscles.
And from that initial infection site, the pus can spread in different directions, like following path of least resistance.
Exactly. The pus follows paths of least resistance through the potential spaces surrounding the anal canal, leading to different types of abscesses. caudally or downwards. The most common type, about 60%, is the perianal abscess, which forms right at the anal margin, confined by the attachments of the longitudinal muscle,
Okay, right near the opening.
laterally or sideways. Pus can track across the external sphincter into the ischiorectal fossa, forming an ischiorectal abscess, about 30%. That's in the large fatty space on either side of the anal canal below the pelvic floor.
Bigger space, maybe less localized pain initially.
Correct. Superiorly or upwards. Less common, pus can track above the anorectal junction into the supralevator space, forming a supralevator abscess. This can be intramuscular or pararectal, depending on its relation to the longitudinal muscle extensions. Figure 80.27 shows a coronal view illustrating these potential sites.
And circumferentially. Around the back.
Yes, the infection can spread around the anal canal in any of these planes, often tracking posteriorly, forming a horseshoe abscess. Figure 80.28 shows an axial MRI view of a posterior horseshoe abscess.
So while most come from anal glands, not all perianal sepsis originates there. Can it come from somewhere else?
That's important. Sepsis in this region can also originate from other sources unrelated to the anal glands. Examples include a submucosal abscess, maybe after procedures like hemorrhoidal sclerotherapy, a mucocutaneous or marginal abscess, like an infected perianal hematoma, ischiorectal abscesses from foreign bodies, trauma or deep skin infections, or pelvirectal supraelevator abscesses that originate from disease in the pelvis, like appendicitis, diverticular disease, gynecological infections, or pelvic malignancy.
And certain underlying medical conditions can make these infections more severe.
Yes, patients with inflammatory bowel disease, particularly Crohn's disease, often develop complex perianal sepsis. Immunosuppressed patients, those with diabetes, HIV/AIDS, or on immunosuppressive medications, are prone to more aggressive and rapidly spreading anorectal infections.
How do these different types of abscesses typically present clinically? How do patients feel and look?
A perianal abscess usually presents with a short history, maybe 2-3 days, of increasingly severe, well-localized pain right at the anal margin. On examination, you'll find a discrete, indurated, hardened, hot, and very tender swelling.
Okay, localized. What about the ischiorectal one?
An ischiorectal abscess, being in a larger space with less tension, might present later with less well-localized pain, but more systemic symptoms like fever and constitutional upset. Examination might show diffuse swelling of the entire buttock with widespread induration and deep tenderness rather than a distinct lump.
And those higher ones, the supralevator abscesses, they sound tricky.
They can be. Patients might only complain of deep rectal pain and fever. There might be nothing visible on external examination. Diagnosis often relies on digital rectal examination, where you might feel tender induration high up, above the anorectal junction, beyond the reach of superficial abscesses.
What other conditions might be confused with anorectal abscesses?
The sources list abscesses connected with pilonidal sinus if it's draining low down, Bartholin's gland abscess in women, or Cowper's gland abscess in men as potential differential diagnoses.
The management is primarily surgical, involving drainage.
Right. Yes, the definitive treatment for most anorectal abscesses is surgical drainage. This is often performed under anesthesia to allow for a thorough examination and adequate drainage. Drainage is typically done through an incision in the perineal skin over the abscess.
How big an incision?
While traditional methods sometimes involved wide excision of skin, like a cruciate incision, the sources emphasize the importance of skin preservation today to reduce wound size and potential scarring while still ensuring adequate drainage. So, often just a simple incision.
Is an underlying fistula always searched for during the drainage procedure?
An experienced surgeon might gently probe the abscess cavity to see if an obvious underlying fistula tract leading to the anal canal is present. If a clear, low fistula is found, a loose draining seton might be placed.
A seton, like a drain.
Yes, essentially a thread or loop left in place. However, the sources strongly caution against aggressive or injudicious probing in the acute setting, as this can create false passages or damage sphincter muscle unnecessarily. Immediate fistulotomy, laying open the fistula, is generally avoided in the acute abscess stage unless the surgeon is highly experienced and confident about the low nature of the tract.
Is packing the abscess cavity standard practice after draining it?
The sources note that packing the drained abscess cavity is a common practice, but it's important to be aware that there's a lack of robust evidence to definitively support its necessity compared to just leaving the wound open to drain. Practice varies.
And for those higher supralevator abscesses, how are they drained?
Their management depends on the origin of the sepsis. If it's clearly originating from pelvic disease elsewhere, that underlying issue needs to be addressed. If it's originating from the rectum or high anal canal glands, drainage might sometimes be performed into the rectum itself to avoid creating a complex extrasphincteric fistula that crosses the sphincters. Summary Box 80.11 summarizes the key points for anorectal abscesses.
That leads us directly into fistulae and ano. It sounds like an abscess is often the first step towards developing a fistula.
It very frequently is. A fistula in ano is a chronic, abnormal communication, essentially a tunnel or tract, that connects the anorectal lumen, usually an internal opening in the anal canal, to an external opening on the skin around the anus or on the buttock. Occasionally in women, it can connect to the vagina. That's an anovaginal fistula. It's typically lined by granulation tissue.
What is the most common cause? Still those anal glands.
Yes, the most common cause is cryptoglandular, meaning it's a consequence of infection originating in one of the anal glands in the intersphincteric space, leading to an abscess that then forms a chronic tract when it drains or bursts.
Are there other causes besides anal gland infection?
Yes, although cryptoglandular fistulas are the majority. Anal fistulas can be associated with or caused by Crohn's disease, a common cause of complex fistulous tuberculosis, certain sexual transmitted infections like lymphogranuloma venereum, actinomycosis, foreign bodies, trauma, rectal duplication, or even malignancy. Though malignancy rarely arises within a long-standing fistula, a non-healing fistula should always be biopsied for that reason.
How do patients typically present with a fistula? What are the symptoms?
The main symptom is intermittent or continuous discharge from the external opening. This discharge is usually purulent, like pus, sometimes bloody. Patients often experience discomfort or mild pain, which might increase until the pus discharges, providing temporary relief. A history of a previous anorectal abscess that either burst or was drained is very common.
Does anything specific suggest a higher origin?
Yes, the passage of gas or even small amounts of stool through the external opening is a strong indicator that the internal opening is higher up, potentially in the rectum, rather than just the anal canal. That's less common but significant.
Fistulas are classified based on their relationship to the anal sphincters. What's the most widely used classification? Parks.
Yes, Park's classification is the most widely used system, based on the course of the primary fistula tract relative to the external sphincter muscle. This classification assumes the internal opening is at the dentate line, arising from an infected anal gland. Figure 80.29 visually represents Park's classification.
What are the four main types in Park's classification? Can you run through them?
Sure. Park's described four main types with approximate prevalence. First, intersphincteric, about 45%. The tract runs downwards in the intersphincteric plane, between the internal and external sphincters. It does not cross the main bulk of the external sphincter. Most go directly to the perianal skin.
Okay, between the muscles.
Second, transsphincteric, about 40%. The primary tract crosses both the internal and external sphincters at a variable level and passes through the ischiorectal fossa to reach the external skin opening. These often have secondary tracts branching off.
Through both muscles. Got it.
Third, suprasphincteric, about 10%. These tracts run upwards from the intersphincteric space above the puborectalis muscle, then loop downwards through the levator ani muscle and the ischional fossa to reach the external opening. The sources note these can be tricky and sometimes caused by excessive probing.
Above the main sling muscle.
And fourth, extrasphincteric, about 5%. These tracts run completely outside the sphincter muscles and the levator ani muscle. They don't have a specific anatomical relationship to the sphincters and usually originate from other sources like pelvic disease, Crohn's, diverticulitis, cancer, trauma, or prior surgery.
The American Gastroenterology Association, the AGA, classification shown in Table 80.2, simplifies this for clinical decision-making by classifying fistulas as simple versus complex.
What defines a simple versus a complex fistula in that system?
Simple fistulas are typically low intersphincteric or low transsphincteric, involving minimal external sphincter, have a single external opening, and are not associated with an abscess, stricture, or significant underlying disease like Crohn's.
Okay, straightforward.
Complex fistulas include high tracts, high inter or transsphincteric, suprasphincteric, extrasphincteric, those associated with an abscess or stricture, those with multiple external openings, recurrent fistulas after previous surgery, and vaginal fistulas, or fistulas associated with underlying conditions like Crohn's disease or prior radiation.
So that simple complex distinction helps guide management.
Exactly. It helps decide whether basic surgical approaches are likely to succeed or if more complex evaluation and management are needed, often requiring specialist referral.
How is a fistula assessed clinically? What are you looking for?
A full history, including continence status, is vital. Clinical examination involves careful inspection to locate the external opening, palpation to feel for induration along the suspected tract, and digital rectal examination to assess sphincter tone and feel for a potential internal opening or induration within the anal canal wall. Proctosigmoidoscopy is also necessary.
What are the key things to figure out?
Key objectives are to determine the site of the internal opening, usually at the dentate line, the external opening, the primary tract's course, and if secondary extensions are present. Also need to rule out other complicating conditions. Is there a rule about predicting the internal opening location based on the external opening? Goodsall's rule.
Yes, Goodsall's rule is a historical guideline illustrated in figure 80.30. It suggests that external openings anterior to a transverse line across the anus usually connect to an internal opening in the anterior midline, while those posterior to the line connect to an internal opening in the posterior midline via a curved tract.
Does it always hold true?
Not always. The sources note that despite this rule, many internal openings, even for lateral or posterior external openings, are found in the midline, so it's a guide, not absolute.
How do you identify the internal opening during the exam?
It can sometimes be felt as a point of induration or seen as an enlarged anal papilla. A helpful trick is to instill dilute hydrogen peroxide through the external opening. The bubbles generated can be seen or heard bubbling at the internal opening in the anal canal, as shown in figure 80.31. Gentle use of probes, as in figure 80.32, combined with digital examination can help delineate the tract's course and its relation to the sphincters, but caution is needed to avoid creating false passages.
The sources emphasize the need for further investigation before surgery for complex fistulas.
Absolutely. If there's any doubt about the fistula's anatomy, its relationship to the sphincters, or the presence of secondary extensions, especially in complex or recurrent fistulas, or those associated with underlying conditions like Crohn's, further investigations are essential for successful management and managing patient expectations regarding continence risk. Don't want surprises in the operating room.
What are the key special investigations used for fistulas? What gives you the best map?
Objective sphincter function assessment with manometry is important, giving quantitative data on tone and length. EAUS provides excellent visualization of the sphincter muscle's structural integrity, which is crucial for planning surgery and assessing continence risk. Using EAUS with hydrogen peroxide instilled into the tract improves accuracy in delineating the fistula and assessing its complexity, as shown in figure 80.33.
But MRI is considered the gold standard for imaging fistulas, isn't it?
Yes. MRI, particularly with fat-suppressed sequences like SDR, provides superior visualization of the fistula tract, its course relative to the sphincters, and crucially the presence of secondary extensions or undrained collections, even those distant from the primary tract. Figure 80.34 and 80.35 show examples of MRI fistula imaging.
So it sees things you might miss otherwise.
Exactly. Its great advantage is demonstrating secondary extensions, which, if missed at surgery, often lead to persistence or recurrence. Fistulography, or CT, might be used if an extrasphincteric fistula originating from pelvic pathology is suspected.
So investigations are vital for mapping the tunnel and the surrounding anatomy before treatment. What are the core principles of fistula surgery? What are the goals?
The twin aims are to eradicate the fistula while keeping the patient continent and comfortable. This is the central challenge, as many fistulas involve the sphincter muscles, and dividing muscle carries a risk to continence.
The source makes a key point about what determines continence after surgery. It's not just what you cut.
Right. It's not simply about how much muscle you divide, it's about the amount of functional sphincter muscle left behind after the procedure. With normal bowel function, continence can often be maintained even after dividing a portion of the external sphincter, provided a sufficient length of healthy muscle remains, often cited as around 2 centimeters, although this can vary.
Complex fistulas represent a significant challenge then.
They do, warranting specialist referral. The multitude of surgical techniques available reflects the difficulty in managing complex fistulas and the fact that no single method is universally successful. There's no one-size-fits-all.
The concept of tract preparation is mentioned. What does that involve?
This is an increasingly accepted approach, particularly for complex fistulas, before performing a definitive procedure. The idea is that persistent infection or epithelialization of the tract prevents healing. A period of drainage, often using a loose seton, allows acute sepsis to resolve and secondary tracts to heal. This can simplify the remaining primary tract and improve the chances of success with a later definitive procedure. Sort of cleans things up first.
Let's discuss the different surgical techniques, balancing cure incontinence. First, fistulotomy, laying it open.
Yes. Fistulotomy involves laying open the entire fistula tract from the external opening to the internal opening, cutting through any overlying tissue, including sphincter muscle if it's within the tract. This is primarily used for intersphincteric fistulas and low transsphincteric fistulas that involve less than 30% of the external sphincter, where the risk to continence is considered acceptable.
Is it used for all locations?
No, it's generally avoided for anterior fistulas in women due to the increased risk to the anterior sphincter anatomy, which is often thinner.
How is a fistulotomy performed?
Under anesthesia, the internal opening is identified. A grooved probe is passed from the external opening through the tract into the internal opening. Figure 80.36 illustrates this. The surgeon assesses the amount of sphincter muscle lying over the probe. The tissue overlying the probe, including sphincter muscle if present, is then divided using a knife or scissors, laying the tract open like a trench. The granulation tissue lining the tract is curetted out and sent for histology, and the wound edges may be trimmed. Marsupialization, where the edges of the open wound are sutured down, can help reduce the wound size and speed healing.
What if the fistula is too high or involves too much sphincter to lay open at once? You mentioned staging.
That's where staged fistulotomy comes in. For deeper transsphincteric or complex fistulas, laying open the entire tract in one go would divide too much sphincter muscle, leading to high incontinence risk. In a staged approach, only a portion of the sphincter might be divided initially, and the remaining muscle component of the primary tract is encircled with a loose suture. Secondary tracts are also laid open or drained. Once the initial wounds heal and fibrosis occurs, the seton-enclosed tract can be divided in a second procedure. This allows gradual muscle division with fibrosis supporting the area, potentially minimizing functional impairment. Hanley's approach for complex horseshoe tracts often uses this principle.
Fistulectomy is another term. Is that different from fistulotomy?
Fistulectomy means excising or coring out the entire fistula tract, often using diathermy. This can provide excellent anatomical clarity on the tract's course and its relation to the sphincters. If the sphincter involvement is low after the coring, the procedure might proceed similarly to a fistulotomy. If the sphincter involvement is high, another sphincter-preserving technique would be needed. Fistulectomy can result in a larger wound than fistulotomy, potentially leading to slower healing.
Setons seem to be used in various ways with a long history. You mentioned loose setons for drainage.
Yes, setons have been used for centuries. It's crucial to understand the intention behind using a seton. A loose seton is typically a non-absorbable, comfortable material, like a surgical tie or vessel loop, placed through the fistula tract and tied loosely, without tension. Its primary purpose is not to cut muscle, but to maintain drainage and allow sepsis to resolve and secondary tracts to heal. Figure 80.37 shows a loose seton in a complex fistula, also associated with Crohn's disease.
So they're used before definitive surgery or sometimes long-term.
Exactly. Loose setons are used as part of staged procedures or as long-term palliation in complex cases or conditions like Crohn's, where definitive surgery carries too high a risk of incontinence. They establish effective drainage to prevent recurrent abscesses.
What about cutting setons? They sound different.
Cutting setons are tied tightly through the fistula tract with the explicit intention of gradually cutting through the enclosed muscle over time. As the seton slowly cheese wires its way through, the muscle heals behind it with fibrosis.
Oh.
This aims to achieve a high cure rate like fistulotomy, but with less functional impairment than dividing a large amount of muscle at once. There's ongoing debate about the optimal amount of muscle to include and the speed of tightening. An Ayurvedic method, Sharasutra, using a medicated thread, works on a similar principle of gradual cutting via chemical cautery and fibrosis.
Let's discuss sphincter-preserving techniques that aim to avoid cutting the muscle entirely. Lift-T is one example. What does that stand for?
Lift-T, or ligation of the intersphincteric fistula tract. It's a sphincter-preserving technique primarily for transsphincteric fistulas.
How does it work?
It involves making an incision over the intersphincteric groove, identifying the fistula tract in the intersphincteric plane, disconnecting it from the internal opening, ligating, tying off, and dividing the tract, and removing the inner portion. The external portion is curetted and drained. Figure 80.38 diagrams the steps. By interrupting and ligating the tract within the intersphincteric space, the main external sphincter is preserved.
What are the results like?
Reports suggest healing rates around 75% with minimal impact on continence, so it's a good option when feasible.
Anal advancement flaps are also sphincter preserving, used for fistulas too.
Yes, similar to their use for fissures, advancement flaps are used to close the internal opening of a fistula with a flap of healthy tissue, thereby eliminating the source of infection entering the tract. This technique is suitable when the sphincter complex is not too scarred or indurated.
How's it done?
After excising the tract, fistulectomy, the internal opening is closed, and a broad-based, well-vascularized flap of anorectal mucosa or skin is mobilized and advanced downwards to cover the closure of the internal opening, suturing the internal sphincter below the dentate line without tension. This technique aims to preserve both sphincter anatomy and function.
Are there biological agents being used? Things to plug the hole.
Yes, there's ongoing research into using biological materials to seal the fistula tract, hoping to promote tissue ingrowth and healing. Fibrin glue and collagen plugs have been tried with variable success. More recently, mesenchymal stem cells injected into the tract and surrounding tissues are being explored, particularly for complex fistulas in Crohn's disease.
Antibiotics are mentioned too, for sepsis.
Yes, antibiotics like metronidazole and ciprofloxacin are valuable for treating acute sepsis associated with fistulas and have some immune-modulating effects that can be beneficial, particularly in Crohn's-related fistulas. However, long-term use can have side effects like peripheral neuropathy or tendinopathy, so need caution.
And biological therapies for Crohn's-related fistulas, anti-TNF drugs.
Yes, for perianal fistulas and Crohn's disease, biological therapies such as anti-TNF agents like infliximab or adalimumab, vilazumab, or cyclosporin are important components of a multimodality treatment plan, often used in conjunction with surgical drainage with loose setons.
What about some of the newer, less invasive techniques? VAFT FIFILAC, OTSC.
Right, the sources briefly mention these. VAFT is video-assisted anal fistula treatment, using a rigid fistula scope to visualize, clean, and treat the tract from within. FILAC is fistula tract laser closure, using a radial laser fiber to ablate the tract. OTSC is over-the-scope clip, placing a large nitinol clip across the internal opening to seal it off.
Are they widely used?
They are newer techniques. Reports suggest variable success rates and potential complications like clip migration or pain. They're still being evaluated. Summary box 80.12 provides a helpful overview of fistula classification, assessment, MRI, stage treatment, setons, sphincter-preserving options, and the role of medical therapy.
Moving beyond cryptoglandular disease, let's discuss hidradenitis suppurativa, or HA. This sounds like a different kind of skin problem affecting this area.
Yes, HA is a chronic, painful condition characterized by recurrent abscesses, sinus tracts, and scarring in apocrine gland-bearing skin. While it commonly affects areas like the armpits, groin, and under the breasts, it can also significantly involve the perineum and buttocks. It causes considerable physical and psychological morbidity.
Is it easy to diagnose?
The source notes that diagnosis can be challenging as there's no single confirmatory test or specific characteristic feature. It's often diagnosed clinically based on the pattern of recurrent painful nodules, abscesses, sinus tracts, and scarring in typical locations. It frequently coexists with acne, pilonidal sinus, and scalp folliculitis, like a pattern of related conditions.
What's the underlying pathology? What's going wrong?
The primary event is believed to be occlusion of the ducts of the apocrine sweat glands in the affected skin. This leads to inflammation, bacterial proliferation, rupture of the gland, and spread of infection and inflammatory material into the surrounding tissue. This secondary infection leads to progressive damage, deformity, and the formation of interconnected subcutaneous sinus tracts. There's also some evidence linking it to relative androgen excess.
How does it present in the perianal area, and how do you distinguish it from a fistula in ano?
HA doesn't usually start before puberty and is rare after age 40. While more common in women overall, anogenital HA is more common in men. Obesity is often associated. In the perineum, it presents as multiple painful raised boils that recur, leading to interconnected sinus tracts, areas of bridge scarring, and multiple draining points.
Okay.
Crucially, while it can rarely involve the anoderm of the anal canal, it does not extend above the dentate line or involve the sphincter muscle. This anatomical boundary is a key feature distinguishing it from a cryptoglandular anal fistula, which originates from a gland at the dentate line and typically involves the sphincters. HA stays in the skin layers.
What other conditions might HA be confused with?
In early stages, simple furunculosis or boils. In later stages, with tracts and scarring, it needs to be differentiated from Crohn's disease, which can cause very complex perianal disease, cryptoglandular fistulas, pilonidal sinus tuberculosis, actinomycosis, lymphogranuloma venereum, or granuloma inguinale. A lot of overlap in appearance sometimes.
How is HA treated?
Treatment varies with severity. Early, mild disease might respond to general measures like weight reduction and antiseptic washes. Antibiotics can induce remission of flares, but often don't provide a long-term cure, and the disease may relapse or progress. Surgery is indicated when antibiotics fail or the disease is progressive and causing significant morbidity.
What's the goal of surgery?
The goal is to improve the patient's quality of life, aiming to be less debilitating than the disease itself. Surgical options range from simple incision and drainage of acute abscesses. For chronic disease with tracts, surgical intervention can involve carefully laying open all the interconnected tracts, which appeals to many patients. For more severe or extensive disease, radical excision of all affected skin is sometimes necessary. The resulting defect might need to be closed with a skin graft or a rotation flap. Occasionally, a temporary defunctioning colostomy is needed to allow severe perianal HA to heal.
Now let's talk about conditions related to human papillomavirus, HPV, starting with condylomata, acuminata, or anal warts, a very common issue.
Yes. There is very strong evidence that sexually transmitted HPV is the primary cause of anal and perianal warts, anal intraepithelial neoplasia, AIN, and squamous cell carcinoma, SCC, of the anus.
The HPV link is key.
Absolutely. The incidence of these HPV-related anal conditions has significantly increased over the past 30 years, particularly in populations with higher rates of sexual activity, especially anal intercourse, and in immunocompromised individuals, such as those with HIV or organ transplant recipients. Similar increases in HPV-related dysplasia and cancers are seen in the female genital tract.
The sources mention a field change concept. What does that mean here?
This is a crucial concept. The HPV virus can affect any squamous epithelium in the anogenital region. Therefore, it's essential to consider the entire area as a potential field affected by the virus. When examining a patient with anal warts, you must also examine the perianal skin and the entire female or male genitalia because the virus and associated precancerous changes or warts may be present in multiple locations. It's not just isolated to one spot.
Are certain HPV subtypes more concerning than others?
Absolutely. There are over 170 HPV subtypes. Low-risk subtypes, particularly 6 and 11, are typically associated with benign conditions like genital warts and lower-grade AIN. However, high-risk subtypes, especially 16 and 18, and to a lesser extent 31 and 33, are strongly associated with progression to high-grade dysplasia, AIN3, and invasive squamous cell carcinoma.
So types 16 and 18 are the main culprits for cancer.
Over 75% of anal cancers are linked to these high-risk subtypes, yes. It's common to find associated warts or precancerous changes elsewhere in the anogenital region in patients with anal cancer.
How do anal warts typically present? What do patients notice?
Many people with HPV infection are asymptomatic carriers. When warts are present, common complaints include pruritus, itching, discharge, bleeding, especially with wiping or pain. Early warts typically appear as separate, small, pinkish-white lesions on the perianal skin and just inside the anal margin on the distal anoderm. Figure 80.39 shows an example.
Can it get large?
Yes, with time, they can enlarge, multiply, and coalesce, covering significant areas of skin. Rarely, they can grow aggressively into very large, cauliflower-like masses called giant condylomata of Buschke-Lowenstein, which can even obstruct the anal orifice.
How is the diagnosis made? Just by looking?
Diagnosis is primarily clinical based on the appearance, often aided by applying acetic acid, which can make the warts turn white. That's acetowhitening. However, biopsy is important to confirm the diagnosis, especially for atypical lesions, and crucially, to assess for the presence and degree of any associated dysplasia or precancerous changes.
What about treatment? Is it easy to get rid of them?
Treatment can be challenging due to that field effect. Even removing visible warts doesn't eliminate the virus from the surrounding area, so recurrence is common. Conservative treatment for discrete perianal warts involves serial application of topical agents like 25% podophyllin. However, podophyllin cannot be used inside the anal canal, intraanally, due to toxicity risks.
The surgery is needed for internal warts.
Yes, surgical excision is a common treatment option and is necessary for intraanal warts or extensive perianal disease.
Describe the surgical excision technique. What's the aim?
Surgical excision is performed under local, regional, or general anesthesia. Local infiltration with dilute adrenaline can help reduce bleeding. The technique involves carefully lifting and separating the wart tissue from the underlying healthy skin or anoderm using scissors or electrocautery, aiming to remove the warts while preserving as much normal surrounding tissue as possible to minimize scarring and maintain function. Careful dissection.
Building on the HPV link, let's discuss anal intraepithelial neoplasia, or AIN. The sources call this a precursor lesion to cancer.
Yes, AIN is a precancerous condition. It's multifocal, virally induced dysplasia, abnormal changes in the cells lining the perianal skin or the anoderm and transitional zone within the anal canal. It's strongly associated with HPV infection, particularly the high-risk subtypes like 16 and 18.
Is it common? Or only in certain groups?
While the prevalence in the general population is low, less than 1%, its incidence is rising significantly, particularly in high-risk groups engaging in anoreceptive intercourse and those with HIV infection.
Who is in those high-risk groups? Who needs to be most aware?
Key high-risk groups include HIV-positive individuals, especially with lower CD4 counts, other immunocompromised patients like transplant recipients, women with a history of high-grade precancerous changes or cancer in other anogenital areas, VIN or CIN, and individuals with extensive or recurrent anogenital condylomata.
How is AIN typically diagnosed? Do people have symptoms?
Often not. AIN is frequently asymptomatic, meaning patients don't notice anything wrong, and the diagnosis is made incidentally when a biopsy of a wart or other lesion shows these dysplastic changes. Increasing numbers, especially in high-risk groups, are being detected through anal cytology screening programs like an anal pap smear.
It's classified by grade, similar to cervical dysplasia, right? AIN, INIP3.
Yes, AIN is graded based on the degree of dysplasia seen on biopsy. A is low grade, A-A is intermediate grade, and A3 is high grade. This reflects how much the normal cell maturation is lost and how far the abnormal proliferative zone extends through the epithelium. A involves the lower third, A3 involves the full thickness. The term Bowen's disease, historically used for A3 of the perianal skin, is now less commonly used. A3 is the preferred term.
What happens if AIN is left untreated? Will it always progress to cancer?
The natural history is somewhat uncertain and likely depends on the grade and the patient's immune status. Progression from AIN3 to AIN3 and then to invasive carcinoma has been observed, particularly in immunocompromised individuals. There is a strong association between AIN3 and anal cancer. AIN3 is found in biopsy samples from about 80% of anal cancers.
And it go away on its own.
Low-grade A and A2 can sometimes regress spontaneously, but AN3 rarely regresses. An estimated 10% of AN3 lesions may progress to invasive carcinoma within 5 years, so high-grade needs close attention.
How does AIN present clinically? What might you see?
As mentioned, it's often asymptomatic. If symptoms are present, they are nonspecific and can include pruritus, pain, bleeding, or discharge. On examination, low-grade lesions may look like slightly raised warts. High-grade AIN3 can appear as areas of thickened skin, hyperkeratosis, or changes in pigmentation. They might be white, red, brown, or irregularly pigmented and can be flat or raised. Any ulcerated area within or near AN should be considered highly suspicious for invasive cancer and must be biopsied. AIN is found in a significant proportion, 28-35% of anal warts that are surgically excised.
How is AN managed? What's the strategy?
Management requires a high index of suspicion, particularly in at-risk individuals, and targeted biopsy of any suspicious areas to confirm the diagnosis and grade. For multifocal or extensive disease, mapping biopsies using a punch biopsy tool at multiple predetermined sites around the circumference and within the canal can help delineate the extent and severity of the disease, often recorded on an operative map or photograph.
For AIN, the high-grade type, what's the standard approach? Surveillance, treatment.
High-grade AN3 requires careful management due to the risk of progression. Regular clinical monitoring with repeat biopsies is essential to detect any invasive cancer early. Specialized centers may use high-resolution anoscopy like colposcopy for the anus with application of acetic acid and sometimes Lugol's iodine to help visualize subtle dysplastic areas that might not be obvious to the naked eye. These areas turn white after acetic acid application, guiding targeted biopsies.
Can AIN be treated surgically? Cut it out.
For localized AN3 involving less than about 30% of the anal circumference, surgical excision can be performed, with the resulting wound left to heal or closed. However, for widespread AN3, particularly involving more than 30% of the anal margin or extending into the anal canal, extensive excision is generally avoided due to the significant risk of causing severe anal stenosis, narrowing, and functional impairment.
So what do you do for widespread disease?
For widespread disease, the affected areas are typically observed regularly, often every 6 months, using anoscopy and targeted biopsies. The sources emphasize caution with aggressive surgery for AIN3, given its uncertain malignant potential and the significant potential for morbidity like stenosis, pain, and poor healing.
What about female patients with ANEs? Is there anything else to check?
It's crucial to examine the entire anogenital region, the vulva, vagina, and cervix, as female patients with ANE are at increased risk of developing other anogenital intraepithelial neoplasia or cancers. Women diagnosed with ANE are typically recommended to have a yearly cervical smear test.
The management strategy is tailored based on the grade and extent of the AN and immune status.
Yes, AA and IN2 are generally considered more indolent, especially in immunocompetent patients, often requiring 12-monthly endoscopy for surveillance. ANI in third and multicentric disease are managed more actively, often by specialists within a multidisciplinary setting. Immunocompromised patients, particularly those with HIV, represent a separate group with higher progression and recurrence rates. They require closer, more extended follow-up, often with 6-monthly endoscopy.
Are there non-surgical treatments for ANI, creams, or medications?
Yes. Topical treatments like imicamod 5% cream, an immune response modifier applied regularly, have shown some effectiveness in inducing regression of AN by at least 2 histological grades. Oral retinoids have also been explored. Newer anti-HPV treatments and therapeutic vaccines are under investigation, while prophylactic HPV vaccination is a crucial strategy for long-term prevention of HPV-related disease, including AIN and anal cancer.
Finally, let's discuss malignant tumors in the anal region. The sources note they are rare but increasing in incidence.
Yes, anal malignancy is uncommon, making up less than 2% of all cancers of the large bowel. However, its incidence has been rising over recent decades, a trend strongly linked to the increasing prevalence of HPV infection, AIN, and immunosuppression, particularly HIV. In the UK, the crude incidence is around 0.65 per 100,000 people, and it's approximately twice as common in women as in men.
What are the main types of anal malignancy? Is it mostly one type?
The vast majority are squamous cell carcinomas, or SCCs. These arise from the squamous epithelium lining the anal canal and perianal skin. Those below the dentate line tend to be keratinizing, while those above the dentate line in the transitional zone can be non-keratinizing squamous variants, sometimes called bacilloid, cloacogenic, or transitional cell carcinomas.
Do those different names matter for treatment?
The consensus today is that all these types behave similarly and are treated collectively as anal squamous cell carcinomas.
What's the next most common type after SCC?
Adenocarcinomas are the next most common, thought to arise from the anal glands. Other rare malignant tumors include melanoma, lymphoma, sarcoma, and other types of skin cancers originating in the perianal skin.
How does anal squamous cell carcinoma typically present? What symptoms should raise alarm?
The most common symptoms are pain and bleeding. Because these are also common symptoms of benign conditions like fissures or hemorrhoids, anal cancer is unfortunately often initially misdiagnosed. This underscores the critical importance of maintaining a high index of suspicion and performing an adequate examination whenever these symptoms are persistent or atypical, especially in at-risk individuals. Figure 80.40 shows an example image of an anal SCC.
Are there less common symptoms?
Yes, patients might present with a palpable mass, pruritus, itching, or discharge. In more advanced stages, the tumor may invade the sphincter muscles, leading to fecal incontinence. In women, anteriorly located tumors can extend into the vagina, causing an anovaginal fistula.
What do you find on examination? What does it look or feel like?
Anal margin tumors often appear as chronic, non-healing ulcers with raised, indurated, hardened edges. Anal canal tumors are typically palpable on digital examination as irregular, indurated, and often tender ulceration or masses within the canal wall. Sphincter involvement can be assessed on digital examination. It's also crucial to palpate for enlarged regional lymph nodes, both in the pararectal tissues and, importantly, in both groins, as this is a common site of spread for SCC.
What investigations are used for staging? How do you see how far it's spread?
Examination under anesthetic, EAU, is essential for a detailed clinical assessment of the tumor's size, extent, and involvement of surrounding structures, and to obtain a biopsy to confirm the diagnosis histologically. Staging involves imaging to assess local extension and distance spread. MRI of the pelvis is used to assess local regional involvement. CT scans of the chest, abdomen, and pelvis are performed to look for distant metastases. PT-CT is increasingly used, particularly for assessing equivocal inguinal lymph nodes and detecting occult distant disease.
How is anal cancer treated? Has it always been surgery? Used to be, right?
Historically, the standard treatment was radical surgery, an abdominoperineal resection, removing the anus, rectum, and creating a permanent colostomy. However, since the late 1970s, combined chemoradiotherapy, popularized by the Negro Protocol, has become the primary curative treatment for most anal SCCs, preserving the anal sphincter and avoiding a permanent stoma in most cases. A major shift.
What evidence supports chemoradiotherapy as the primary treatment?
Landmark clinical trials, such as the UKCCC-CAR ACTI trial, demonstrated that adding chemotherapy 5-fluorouracil and mitomycin C, or cisplatin, to external beam radiotherapy significantly improves local tumor control compared to radiotherapy alone. Subsequent trials, like ACT2, compared different chemotherapy regimens, establishing the preferred combination of mitomycin C and 5-fluorouracil, typically delivered as a continuous infusion.
Are treatments still evolving?
Yes, current trials are investigating ways to personalize treatment based on tumor size and response, including potentially local excision for very small tumors or varying radiation doses.
When is surgery still necessary for anal cancer if chemoradiation doesn't work?
Radical surgical excision, specifically abdominoperineal resection, AP resection, is used as salvage therapy. It's indicated for patients who have persistent tumor after completing chemoradiotherapy, for managing severe complications of treatment such as non-healing ulcers, strictures, or fistulas, or for recurrent disease after initial successful treatment.
How often is salvage surgery needed?
Despite the success of chemoradiotherapy, about 20-25% of patients will have an incomplete initial response or experience local recurrence, requiring careful assessment before salvage surgery. For very locally extensive tumors involving surrounding pelvic organs, more complex pelvic exenerative procedures, often requiring reconstruction of the perineum using a muscle flap, might be necessary.
What about lymph nodes, particularly those in the groin? How are they managed if involved?
Enlarged inguinal lymph nodes are common and can be due to either inflammation or malignant spread from the anal cancer. Histological or cytological confirmation biopsy or fine needle aspiration is absolutely mandatory to differentiate between benign reactive enlargement and malignant involvement before making treatment decisions.
And if they are malignant?
If malignancy is confirmed in the groin nodes, they are typically treated with chemoradiotherapy. Surgical removal of the lymph nodes, radical groin dissection, may be considered for residual or recurrent nodal disease after chemoradiotherapy, but it carries significant morbidity, so it's not undertaken lightly.
Are there other anal malignancies besides SCC? You mentioned adenocarcinoma.
Yes, though less common. Adenocarcinoma in the anal canal is usually an extension of a low rectal adenocarcinoma. Rarely, it can arise directly from the anal glandular epithelium or develop within a long-standing chronic anal fistula. This is a key reason why any non-healing fistula tract or associated mass should be biopsied.
How are those treated?
These adenocarcinomas are generally treated like low rectal cancers, often requiring abdominoperineal excision with or without neoadjuvant chemoradiotherapy.
And melanoma.
Malignant melanoma of the anus is exceedingly rare and carries a very poor prognosis. It often presents as a bluish-black mass, but can also be a melanotic, non-pigmented, sometimes mimicking a thrombosed external hemorrhoid, again highlighting the need for biopsy of suspicious lesions. Perianal Paget's disease, a rare intraepithelial adenocarcinoma, can also occur but is exceedingly rare. Summary box 80.13 provides key information on anal cancer.
Finally, let's discuss non-malignant strictures, specifically anal stenosis, a narrowing of the anal canal. What causes this?
Anostenosis is a rare but potentially very debilitating complication. It's most commonly caused by prior anorectal surgery, particularly hemorrhoidectomy, if too much anoderm or mucosa is removed, or if adequate skin bridges are not left between excision sites, leading to circumferential scarring and narrowing.
So a complication of surgery usually.
Most commonly, yes. It can also occur after stapled hemorrhoidopexy or colonal anastomoses, bowel connections low down after rectal removal. Other causes include trauma, fibrosis after radiation therapy, chronic inflammatory conditions like tuberculosis, fibrosing skin conditions like scleroderma, or inflammatory strictures like those caused by lymphogranuloma inguinale.
Can inflammatory bowel disease cause strictures in this area? Crohn's or UC?
Yes, strictures, often annular or ring-like, are a known complication of Crohn's disease in the anal canal and rectum due to transmural inflammation and scarring. Occasionally, an anal stricture can occur in ulcerative colitis, though less common, a critical point from the sources. Until proven otherwise by biopsy, any stricture in the anorectal region, whether suspected benign or inflammatory, must be assumed to be a carcinoma until histology confirms otherwise. Biopsy is essential.
Can endometriosis cause a stricture here?
Yes, Endometriosis of the rectovaginal septum, where endometrial-like tissue grows between the rectum and vagina, can cause a stricture or mass-like effect, often presenting with symptoms of painful defecation and pain related to menstrual cycles, particularly severe pain during the first couple of days of the period.
What are the typical symptoms of anal stenosis? How does it feel for the patient?
The leading symptom is increasing difficulty with defecation. Patients often find they need to use progressively stronger or larger doses of laxatives or aperients to have a bowel movement. If the stool is formed, it may be described as coming out in a very narrow pipe stem shape.
Right.
If the stricture is due to inflammation, there might be associated tenesmus, that feeling of incomplete emptying bleeding, or mucopus. In severe cases, the patient might only present when they develop symptoms of subacute or even acute intestinal obstruction.
What do you find on rectal examination? How do you diagnose it?
On digital examination, the examining finger encounters a sharply defined shelf-like obstruction or narrowing of the lumen. If the stricture is wide enough to admit a finger, you can assess if it feels like a short, annular ring or a longer tubular narrowing, although this may require gentle dilatation or examination under anesthesia to fully appreciate.
And biopsy is mandatory.
Absolutely mandatory to take a biopsy of the stricture tissue to rule out malignancy. The examination can be quite painful, and a thorough assessment, including biopsy and gentle graduated dilatation, may need to be performed under general anesthesia.
How is anal stenosis treated? Can it be stretched?
For mild stenosis, non-operative management is recommended, focusing on keeping the stool soft with stool softeners and fiber supplements to make passage easier. Dilatation is a primary treatment for many strictures. Initially, this may be done gently under general anesthesia, and then the patient is taught to perform regular self-dilatation using an anal dilator at home. Regular dilatation can be sufficient for many anal and even some rectal strictures.
What if the stenosis is severe or doesn't respond to dilatation? Is surgery needed?
For severe anal stenosis, particularly post-surgical strictures where tissue has been lost, anoplasty is indicated. This is a surgical procedure to reconstruct and enlarge the anal opening by incising the strictured area and bringing in a flap of healthy perianal skin and subcutaneous tissue to replace the lost tissue and widen the lumen. Figure 80.41 shows a diagram of a YV advancement flap, a common technique for anoplasty. Brings in new tissue.
What about colostomy? Is that ever needed?
A diverting colostomy might be necessary if the stricture is causing intestinal obstruction or, in very advanced cases, complicated by severe fistulas. This provides symptomatic relief. In selected cases, particularly for post-surgical strictures where the rectum above is healthy, the strictured segment can be excised and continuity restored with a colonal anastomosis. However, the sources note this restorative procedure is contraindicated in Crohn's disease due to the high risk of recurrence of the anastomosis.
Wow. That was a truly deep dive into the anatomy, physiology, examination, and an extensive range of conditions affecting this crucial area. From the delicate muscular control and surprising blood flow patterns.
Yeah, those aviations.
To the complex interplay of factors leading to incontinence and the intricate management of conditions like fissures, haemorrhoids, abscesses, and fistulas. A lot going on down there.
It really is a region of fascinating complexity where a detailed understanding of the anatomy directly informs clinical diagnosis and treatment. Learning about the specific layers, the nerve supply differences, and the typical pathways of disease spread is fundamental to grasping these conditions.
And we explored how things like HPV infection have changed the landscape, highlighting the importance of screening and recognizing precursor lesions like AIN alongside overt malignancy. That's been a huge shift.
Absolutely. And how management has evolved, moving towards less invasive options when possible, sphincter-preserving techniques for fistulas, neuromodulation for incontinence, and multimodality approaches for complex conditions like Crohn's or anal cancer.
It reinforces the idea that even seemingly basic symptoms in this region warrant careful evaluation, given the range of potential underlying issues, from the very common, like fissures or piles, to the potentially serious, like cancer.
Exactly. Being informed about this area means understanding not just the names of conditions, but the underlying mechanisms, the crucial diagnostic steps, and the principles guiding treatment decisions.
So for you listening, this deep dive hopefully provides a much richer understanding of a vital part of your body and the sophisticated ways it functions. And is managed when problems arise.
Yeah, it highlights that symptoms should be discussed with the healthcare professional
Yeah.
and that a thorough evaluation is key to accurate diagnosis and effective treatment. Don't ignore things.
Definitely not. And perhaps it leaves us with a thought for further reflection. As we continue to refine our understanding of chronic inflammatory conditions, nerve function, and maybe even the microbiome's role down there, how much more will our approaches to managing complex issues like functional bowel disorders, chronic pain, and inflammatory conditions in this region shift away from purely structural or surgical interventions towards more holistic or targeted biological and physiological therapies?
And how will technologies like advanced imaging and genetic profiling further personalize our approach to conditions ranging from incontinence to cancer in this often challenging area? Where does it go next?
Those are certainly questions that keep the experts in this field digging deeper.
Thank you for joining us on this deep dive.
Thank you.